And in NMOSD, it is also more frequent to see microcystic macular edema that we can see here in the inner nuclear layer that is interpreted as from the Muller cells and associated with possible traction of the inner nuclear layer from the loss of axons. Also, NMOs show more severe vascular retinal damage found using OCT angiography, as we can see in these examples, and on the left, one from China. But also, the visual evoked potentials are differently affected in the two diseases. It was already shown from a Brazilian cohort that the VEPs are less affected in latency compared with amplitude, which is more affected, or they can even be absent in NMO acti-aquaporin positive patients. Therefore, in MS, we find a good correlation between demyelination from delayed VEPs and the extent of axonal loss at OCT, while in NMO spectrum disorder, we find severe axonal loss without a so severe VEP delay because of the lack of the same amount of nude axons. And also in anti-MOG IgG syndrome, there is this old-fashioned point of view that the recovery is much better compared with MS and with NMO, but we should consider that these patients tend to be quite young. And if we check the OCT, we can see that with the accumulation of episodes, we can have a very severe axonal damage. So this is a disease not to underestimate. Also, in this other study, we could have the demonstration that in a MOG IgG, the accumulation of different episodes of optic neuritis leads to a very severe axonal loss. So treatment must be very early and aggressive also in these patients to prevent the accumulation of attack and of axonal damage. But the axonal damage has an important prognostic factor. This is quite relevant if we consider OCT, for example. In this multi-center study from Elena Martinez-Apicina, we could see in almost 900 patients that in the early phases of MS already had a baseline retinal nerve fiber layer thinning were more likely to worsen in their disability within the next 2 years, showing that their axonal reserve is already exhausted. But we can use them also to monitor disease. Patients with evidence of disease activity defined clinically and with new or enhancing lesions have more neuroaxonal loss in the retina over time compared with patients without, who are not fully stable, as they can show some axonal loss. As you can see here, the delta is not zero. But MS patients who are NIDA have more ongoing axonal loss compared with stable patients with NMOSD. So these two pieces of evidence suggest that NIDA3 is not enough to monitor MS. And we can use these tools also to show improvement, mainly remyelination. And for this, the best candidate is the neurophysiology. For example, after optic neuritis, the VEPs have been used as a primary endpoint in a phase 2 trial on using opicinumab, demonstrated a better recovery after optic neuritis of VEP latency. And also in chronic VEP delay, treatment with clemastine demonstrated significant improvement in latency compared with placebo that then did show the recovery when the placebo group received clemastine. And also, this is the last example, quite recent, showing with multifocal VPs an improvement compared even with healthy people of VP latencies after the treatment with alemtuzumab, suggesting that immunomodulation and immunosuppression may open the path for endogenous mechanisms of remyelination. So we may conclude that both CT and OCT can help in the diagnosis, mostly in the differential diagnosis, especially between MS and NMOSD, have some prognostic indication, especially in MS, and can help monitoring disease activity, mainly OCT, with neurodegeneration that occurs even without optic neuritis, and remyelination, and for this, the best candidates are VEPs. And with this, I thank you very much for your attention.
I think we will take questions at this stage. Are there any questions to ask Professor Letizia? I think she will be happy to answer any questions on this topic. To start with, can I ask Professor Letizia, what's the mechanism of RNFL thinning in MS? Is it retrograde axonal degeneration?
Oh, thank you very much. I take the occasion to thank so much for inviting me to this important event. And actually, your question leads to an important issue, which is whether the degeneration is from inflammation taking place locally in the optic nerve or even in the retina, as shown by recent data that are going to be published soon from histology of the optic nerve. And so even if the disease activity seems not there from, for example, MRI monitoring, there is still ongoing inflammation in the optic nerve, especially people with active MS. So it seems that the degeneration occurs not necessarily from attacks and from optic neuritis, recent optic neuritis, but from ongoing inflammation. So it could be used as a marker of this activity. We should focus more on the inner nuclear layer to check the presence of inflammation. But there should be two separate mechanisms. One, as you say, from retrograde degeneration, but it could also be that ongoing inflammation is there locally.
Yeah, Letizia, can I just ask a quick question? Now, you told us that the VP will be immediately abnormal, but the OCT may not be having changes immediately soon after optic neuritis. So is there a, from a clinical point of view, when to do the OCT? Should it be done later or immediately like the VEP we do for optic neuritis?
Thank you very much. I think, for example, when a patient comes into the emergency department, we tend to do both at the same time, even though a normal OCT is a better prognostic factor, because early severe edema acutely can be an indicator of a potential risk for axons. And so I don't think we should wait to do the OCT just because it's going to become abnormal later, because it can give you prognostic indication even at the same time of VP. But a VP can be important also to demonstrate that the patient has no functional or psychogenic visual loss, which sometimes happens, and sometimes it happens also in people with MS. They have MS, but they can have some symptoms they're not sure about, or maybe they're psychogenic. So a normal VP with a severe visual dysfunction is like a red flag for that. So we tend to do both.
Can I ask another question? Actually, two questions in one. This is about electroretinography. Now, pattern ERG has a optic nerve head component. So how does it behave in MS? That's number one. Number two, if the inner nuclear layer is affected, how does the full field ERG behave in MS, optic neuritis?
Thank you very much for this question. I have to say I have a bias because we don't do them in our lab. But I would like to reassure you that the issue is that the sensitivity of ERG is not comparable to that of VPs in case of optic neuritis. And I said I have a bias because I'm a neurologist, so I leave it to the ophthalmologist for retinal diseases. But as in optic neuritis, the sensitivity is not so comparable with that of VPs. I tend to optimize the resources and do the VPs instead. But multifocal can be more sensitive and more detect focal lesions in the optic nerve. So sometimes the full field VPs are normal, but the multifocal VPs can give you better information. So in some cases, I would add that.
Thank you very much, Professor Letizia. I think in the interest of time, we will stop the Q&A session and go on to the next lecture. And we express our appreciation in the usual manner.
Thank you so much.
It's a great pleasure to introduce the next lecturer. He's Professor Jeffrey L. Bennett from USA. He's from the University of Colorado School of Medicine, and his special interest in neurodegenerative disorders. He will be speaking to you in OCT in neuroimmunology. It's over to you, Professor Bennett.
Okay, I'll wait. Hopefully my screen will be enabled to share with you. Currently blocked. Hang on for a second, sorry. Let's see if that can work here.
Professor, you can share the screen right now.
Ask some. Hang on. I apologize. I will need to come back in. I apologize.
Do you want some help, sir?
I will come back into the meeting in a second.
Okay.
Okay, I am back. I apologize for that. And can you see my screen now? Can you see my screen?
Yes, we can see.
We can see
it. Yes.
And it's the correct presentation? I'll make sure the,
So
So-
there's a small problem with your sharing. You're sharing your extended screen. So
okay, how about now?
okay, right now. That's good. That's good. That's better.
Yeah, I apologize. That's why I wanted to know which screen I was sharing here. But thank you very much. I'd like to thank the meeting organizers for the kind invitation to speak to everyone on OCT and neuroimmunology. And in particular, following that fantastic lecture by Dr. Leocani, you've gotten the basics of the power of electrophysiology and OCT to assist in the management and investigation of optic neuritis and multiple sclerosis patients. In my lecture, I wanted to focus on first, no relevant disclosures, but in my lecture, I wanted to focus on three major goals regarding OCT and neuroimmunology. The first is to introduce the technology of OCT. And in particular, I know that members of this audience likely have a diverse experience with OCT, but I want to level the playing field, so to speak, and provide a basic background so that everyone can be familiar with how OCT works, how anatomic data is derived from the images, and introduce the rather new technology of OCT angiography. Second, I want to review the capabilities of OCT to reveal optic nerve and retinal pathology. Understanding those capabilities, I think, is essential to understand its potential usefulness and limitations in the care of patients with neuroimmunologic disorders. And finally, I want to take a look at the current and future role of OCT in the diagnosis and monitoring of neuroimmunologic patients and its potential to advance our understanding of neuroimmunologic disorders. So let's get going. First with OCT technology. OCT is a non-invasive light-based imaging technology that uses interferometry to generate high-resolution cross-sectional images of the retina and optic nerve head. The first in vivo images were published in 1993 and clinical use soon followed. Technologic upgrades from time domain to spectral domain technology have improved resolution and speed. And as shown in the montage in the bottom right corner here, you can see from the first image in 1993 through time domain and spectral domain technology that there's been a resulting increase in the resolution, which is now almost histologic. So as a result, there are broad uses for diagnosing, prognosing, and monitoring treatment of various disorders. How does OCT work? Consider it analogous to sound-based ultrasound, but with low coherence light. OCT measures the intensity of back-reflected light to create cross-sectional images based on the variable optical reflectance properties of retinal tissues. Initial time domain machines split the light source into a reference beam and sample beam and used a stepper motor here to compare the interference of reference and back reflected sample beams over the depth of the optical section. Now, spectral domain machines use a spectrometer to deconvolve the interferometry signal against the reference beam. The result allows for increased speed and resolution with tens of thousands of A-scan images acquired and assembled into cross-sectional B-scan images. These B-scan images, as shown here, can be assembled into volumetric images, and current spectral domain machines have a greater sensitivity and speed than ever realized with time domain machines, with current resolution of 3 to 5 microns. And you can see the difference between this time domain image on the left and the spectral domain image on the right. What scans and information does OCT provide in spectral domain? those can be differentiated with two different light sources now for spectral domain OCT. Now you can get OCT in the spectral domain using either low coherence diode lasers at about 840 nanometers or a tunable laser of a slightly higher wavelength using swept source technology. Due to the tunable wavelengths of swept source technology, if you're interested in those, they provide a greater depth of imaging and a greater speed of acquisition. They, however, sacrifice a little bit of axial contrast. With that said, OCT scans of the optic nerve head give us image analysis of the peripapillary retinal nerve fiber layer. In general, optic nerve imaging is performed with OCT using a circumpapillary 3.4 millimeter diameter scan centered on the optic nerve. This scan is essentially unrolled and automatically processed with a segmentation algorithm to delineate the peripapillary retinal nerve fiber layer going from the interlibening membrane up top to the lower boundary of the RNFL below. The difference between these boundaries is determined to be the retinal nerve fiber layer thickness, and that's generally shown as a profile as it's unrolled from the temporal region in 360 degrees around to the other temporal region. When focused on the retina, the OCT essentially provides us with an optical tissue biopsy. And this biopsy allows us not only to segment the retina into various layers as shown here, but to observe it qualitatively for tissue abnormal signals. One of the foremost uses for the macular OCT retinal scan is to examine those ganglion cells, more than 50% of which exist in the macular region. Using segmentation algorithms, the ganglion cell layer and adjacent interplexiform layer, as you heard of just in the prior lecture, can be quantified to provide a very sensitive measure of optic nerve injury. Because the interplexiform layer and ganglion cell layer can't be separated, they're put out as a joint GC plus IPL analysis. And finally, there is OCT angiography. Technologically, this is analogous to MR angiography. And this is a rather new instrument making its way into neuroimmunologic disorder analysis. It's analogous to MRI angiography in that repeated scans of OCT are used to detect motion using amplitude decorrelation or phase variance. Hundreds of thousands of A scans are performed in repetition, and the total scan time is on the order of 10 to 15 seconds. It is automatically segmented into 4 zones: the superficial retina, deep retina, outer retina, and choriocapillaris. And information from each of these layers can be used to be helpful in making diagnoses and assisting with evaluating the patient in front of you. The problems with this technology right now are that because of the repetitive nature of this scanning technology, it is extremely sensitive to motion artifact. And because there can be reflection between layers, there can be projection artifacts where vessels from one layer interfere with the interpretation of other layers. This makes the technology very sensitive to segmentation error and media opacities, and can even be fooled by the presence of some extravascular signal. For many of these reasons, OCTA has been used mostly for the qualitative analysis of patients in front of you, and it can be used very rarely in any quantitative longitudinal sense at this time. So now that we've gone through technology, I want to take a look at OCT and ocular pathology. What can OCT tell us about what's going on in the eye of the patient in front of you? First and foremost, when focused on the optic nerve, OCT is excellent at revealing post-inflammatory optic atrophy in your neuroimmunologic patient. As shown on the left-hand side and the right-hand side, we are looking at an acute optic neuritis patient with the RNFL and ganglion cell layer analysis performed at the acute setting and following 6 months. And what can be seen is there might be some slight thickening in the acute setting of the retinal nerve fiber layer. but no obvious impairment of the thickness of the retinal nerve fiber layer and ganglion cell layer. But after 3 to 6 months, 6 months in this instance, you see local atrophy of the acutely affected right optic nerve in this patient, with loss of ganglion cell interplexiform layer thickness on the right side as well. What you're observing is thinning, not necessarily proving a mechanism, but obviously in this case, post-inflammatory optic atrophy. On the flip side, retinal nerve fiber layer thickening can be observed by OCT, and it must be interpreted about what that thickening may represent. In this instance, I'm showing you on this right hand or left hand side of the screen as you're viewing, you can see that there's thickening of the retinal nerve fiber layer in both eyes in this instance. Does this represent swelling? In fact, in this instance right here, which is a young patient with pseudo-swelling from optic disc drusen, you're seeing a mixture of severe swelling of the optic nerve as well as underlying drusen. But what I want to point out in this instance on the right is that there are many hints qualitatively that you can use OCT to hint at the source of the optic nerve head swelling. In this instance, on the left, you have papilledema, optic nerve head swelling from elevated intracranial pressure, where you can see the inward angle deflection of Bruch's membrane, indicating that pressure pushing from the outside into the globe of the optic nerve head. On the right here, you see swelling from ischemia without this inward deflection of Bruch's membrane. In the bottom, you can see swelling associated with deposits within the inner nuclear layer, the outer nuclear layer of Henle, where you have it, with neuroretinitis. And on the far bottom right, you see inflammation. This is a case of MOG-associated optic neuritis, where there might be even these peripapillary hyperreflected ovoid mass-like structures, which are abbreviated PHOMS, PHOMS, which can be seen in multiple types of optic nerve pathologies, but are thought to represent the consequences of axoplasmic stasis. Here, you can also use OCT to look at deposits within the optic nerve head. In this case of optic nerve head drusen, you can see drusenoid material in between the two edges of the opening to the optic canal as hyporeflective entities with hyperreflective edges as outlined by these yellow triangles. And using other technologies such as autofluorescence available on certain OCT machines, you can see these calcium deposits essentially glow within the optic nerve head to help you confirm the entity of why a patient's optic nerve might be swollen. This is particularly important for many patients appearing with optic disc swelling in the emergency room. And then finally, the OCT focused on the retina can detail many different fluids and deposits. I'm not going to go through all potential retinal pathologies, but those of particular note in neuroimmunology you might see, including microcystic intermacular edema, as noted in the previous lecture, retinal drusen, which can often be confused with other deposits as shown here on the inner side of the retinal pigment epithelium that are due to outer retinal deposits from autoimmune retinopathy. So seeing how OCT can show you thinning and thickening and fluid and deposits in various levels of the retina. So now I want to focus finally on how we can use OCT to help us with our neuroimmunologic patients. What can we know right now? Where are we going? And where are our uses? First, we'll take a look at the obvious, something that involves vision and optic neuritis. We've known for quite some time, since time domain OCT arose, that there was retinal nerve fiber layer loss in eyes affected by optic neuritis. In fact, the average thinning of the retinal nerve fiber layer was approximately 20%. But in those studies, we also observed that in MS eyes that were paired width of eye previously affected by optic neuritis, or even in MS eyes in a patient who never had symptomatic optic neuritis, there was evidence of silent retinal nerve fiber layer loss. And this retinal nerve fiber layer loss, until it got to a significant extent, did not appear to associate with vision loss unless it reached a critical level, or this inflection point at approximately 70 microns. This isn't an absolute inflection point, but it appreciates that there was essentially some room to spare for retinal nerve fiber layer loss when it came to central acuity and visual field, but repeated events of injury would ultimately result in vision loss. Subsequent studies using OCT and optic neuritis have shown us a strong correlation between OCT and visual function, both with high contrast vision as well as low contrast vision, and also color vision. And these associations occur not only with the peripapillary retinal nerve fiber layer, but also in the papillomacular bundle thickness, as well as areas of the retina. As shown on the right, low contrast vision loss correlated with ganglion cell interplexiform thickness, the greatest when it came to optical coherence tomography measures, showing us that in essence, what we're observing with retinal nerve fiber layer atrophy and ganglion cell interplexiform loss ultimately correlates with visual function, at least explaining about 25% to about 50% of the variance. The problem with OCT and optic neuritis is that this retrobulbar optic neuritis is being measured by ganglion cell thinning and retinal nerve fiber layer loss remotely in the retina. And as mentioned in Dr. Leocani's lecture, this takes time to observe. In fact, in terms of the retinal nerve fiber layer, it takes about 3 months for most retinal nerve fiber layer loss to be noted, and about 6 months for the steady state of permanent extent of retinal nerve fiber layer loss to be noted. But ganglion cell interplexiform loss can be noticed a little bit early, raising the question of what are we noticing here in this measure? How are ganglion cells being lost earlier than their cable? And or are we looking at not necessarily ganglion cell loss, but loss of the dendritic tree in the interplexiform layer? When it comes to prognosis of optic neuritis, you've heard about OCT predicting poor visual function. Well, by Dr. Villaslada and colleagues, they noticed that early vision loss and more poor recovery can be predicted by ganglion cell interplexiform thinning at 4 weeks afterwards, with more prominent loss, 4.5 and 7 microns of thinning at 4 weeks, pointing to increased risk for low contrast visual acuity loss, as well as visual field loss and color vision loss. The issue with this is that while the sensitivities and negative predictive values are high, the positive predictive values and specificity are rather low, pointing to the power of this indicating perhaps a better prognosis if you don't have anything at 4 weeks, but a little bit unknown if you do have atrophy evident at 4 weeks already in the system. And the problem is 4 weeks is a little bit late, however, to address further interventions immunologically for the care of the optic neuritis. What this visual association may be is that it may be more important, particularly with what type of injury is occurring. Recently, in a publication by Sachiris and colleagues, they looked at 135 subjects with various types of optic neuritis. And the visual acuity more often typically was worse in aquaporin 4 than MOG optic neuritis, and worse in both of those than MS optic neuritis, despite similar levels of ganglion cell interplexiform thinning. And independent of any cystic macular edema in the internuclear layer, aquaporin 4 optic neuritis appeared to have worse visual function per a similar level of ganglion cell thinning, suggesting that perhaps these cases of aquaporin 4 optic neuritis have something else affecting the retina that is limiting visual recovery beyond just what is affecting the optic nerve and ganglion cell layer. So we'll have to stay tuned, but OCT may have powerful independent predictive ability based on the type of optic neuritis that's occurring. When it comes to diagnosis, however, OCT alone is not going to differentiate for you the difference between MOG, MS, and aquaporin 4 optic neuritis. Here was a nice meta-analysis recently published showing that for peripapillary retinal nerve fiber layer thickness and for ganglion cell interplexiform layer thickness, while aquaporin 4 optic neuritis tended to cause thinner peripapillary retinal nerve fiber layer and ganglion cell layer than MS, as well as MOG did, you could not differentiate simply between aquaporin 4 disease and MOG disease based on these measures. So therefore, you're going to have to use clinical intuition and not be dependent on OCT, even post hoc, to be able to easily differentiate these forms of optic neuritis. When it comes to OCT angiography, you heard that OCT angiography in the past lecture has shown some nice differences between NMO spectrum disease, optic neuritis, and MS optic neuritis when it comes to the ratio of angiographic loss in the radial peripapillary capillary density plexus, as shown here, dropout in NMO, less dropout in MS. And these ratios can be helpful in perhaps differentiating these, but again, these analyses were performed 6 months after these optic neuritis events occurred. So nothing that is pointing to an acute help in making a diagnosis. And at 6 months, you'd best be doing the serology to differentiate these two entities. So let's take a look at OCT and multiple sclerosis diagnosis. And yes, I mean multiple sclerosis diagnosis. There's been some nice recent work by colleagues in NYU looking at receiver operator curves, looking at can we identify a history of unilateral optic neuritis by inter-eye OCT differences in either the peripapillary retinal nerve fiber layer or the ganglion cell interplexiform layer. This analysis, performed with colleagues around the world, totaled almost 1,900 MS subjects, and additional functional information was available about them in their high contrast vision, low contrast vision, and ganglion cell interplexiform layer thickness. And what they determined was that a 5 micron difference in the peripapillary retinal nerve fiber layer between the two eyes average, or 4 micron difference in the ganglion cell interplexiform layer, had the highest diagnostic sensitivity for representing a probable prior history of optic neuritis in a patient. This correlated with a 5.7% decrease in peripapillary retinal nerve fiber layer thickness, or a 5.7% decrease in ganglion cell interplexiform layer thickness. And these differences correlated with different functional high contrast and low contrast acuity in the thinner eye. This correlated quite well with earlier, smaller analyses showing that a similar percentage inter-eye difference could diagnose prior optic neuritis in MS patients. A recent study looking at a cohort across the UK found that some confounding factors should be considered. You should not look at such analysis in patients that are older, of non-white ethnicity, and with a history of prior eye disease or diabetes. But outside of those conditions, again, a cutoff of about 4 micron difference in ganglion cell interplexiform layer thickness was diagnostic of prior optic neuritis. And if you think about this as being helpful, imagine a patient with a clinically isolated syndrome who doesn't have enough information by MRI for determination of dissemination in space. One could get dissemination in space issues by OCT differences, as well as potential dissemination in time issues, since it takes about 3 to 6 months to detect maximal thinning of the retinal nerve fiber layer and ganglion cell interplexiform layer. So I think moving forward, we're going to see OCT in the next iterations possibly be incorporated into the care of MS diagnosis with the new McDonald criteria. Multiple sclerosis, as you also heard, can have inflammatory activity detected by OCT. And Dr. Leocani pointed out that inner nuclear layer thickness correlates with MS disease activity. Back in 2016, the group in Munich noted that there was a correlation between inner nuclear thickness and increases in T2 lesions, relapses, and NIDA3 characterization across a cohort of MS patients. And these odds ratios were dependent just on a 1% change in the inner nuclear layer thickness. And as you can see in the graph below, inner nuclear layer thickness correlated particularly with increased thickness in those patients not meeting NIDA3 diagnostic criteria. In a subsequent recent analysis, it was shown that while all analyses as shown in the top portion of this graph in OCT may correlate with optic neuritis related injury, inner nuclear layer thickening was the only measure to correlate with MS relapse activity. And it didn't correlate acutely, but it correlated with changes that were roughly remote from the time of relapse. So in general, inner nuclear layer thickness may be an alternative measure to assist with longer-term assessment of ongoing inflammatory activity. Can OCT tell us about multiple sclerosis progression? We've known for quite some time that retinal nerve fiber layer loss correlates with brain atrophy. That is, OCT is correlating with measures of both white matter and gray matter atrophy in MS. As shown in the multiple studies on the left here, that RNFL thickness correlates, interestingly, with white matter volumes more than brain parenchymal fraction and gray matter volumes, despite the fact that you're correlating axonal thickness with brain thickness here. That retinal nerve fiber layer thickness correlates with T2 lesion volume and more than T1 related black hole lesion volumes. And that retinal nerve fiber layer thickness using more sophisticated MRI measures can correlate with both injury as determined by diffusion tensor imaging and radial diffusivity, as well as with damage both inside in the optic radiations and outside the visual pathways. The problematic nature with such analyses still is that retinal nerve fiber layer thickness correlates alterations in those areas, but it is notably worse in non-Caucasians, perhaps giving us an avenue for cheaper evaluation of volume loss and atrophy, which is most correlative with functional disability in MS patients. Because when we look at the correlation between OCT measures and EDSS, we see some studies with nice correlations and others without. Those that have nice correlations tend to be evaluating MS-affected optic neuritis eyes only, while others found that the correlation could be improved by analyzing the GC plus IPL layer. What this probably represents with this variability here is that the EDSS really represents vision poorly and is probably not an ideal measure for trying to correlate OCT analyses. What has been pointed out previously in the last lecture was that OCT changes can occur in eyes not affected by optic neuritis over time. And so we really have to learn more about this because it's a little bit unclear what is really being measured. Is it inflammatory or degenerative phenomena? Is it neuronal or axonal loss, or is it merely axonal thinning? And how does this measure add to what we would determine as our current measures to really promote the alteration of ongoing what may be apparently good therapeutic response? And finally, OCT can tell us a little about multiple sclerosis pathology. There was an interesting pathologic correlate noted by OCT in some MS patients. Typically, when we see retinal nerve layer loss on the left here, we see a cording macular thinning. But in a study by Seda and colleagues in Brain in 2011, they noted that they found a fraction of MS patients that had preserved retinal nerve fiber layer thickness, but isolated macular thinning, a phenomena they called macular thinning predominant, or MTP. These patients had a 95th or normal percentile of retinal nerve fiber layer thickness, but an average macular thickness below the 5th percentile. They accounted for about 10% of their MS patients, and they had unique host of both retinal and optic nerve visual symptoms, as well as visual function that showed reduced low contrast acuity and a difference between their visual function between MS patients who had these MPT phenomena and those that didn't, including altered multifocal ERG responses. A subsequent study, however, with a larger group of patients, didn't identify a cohort of patients that really fell into this range of isolated macular volume loss with preserved retinal nerve fiber layer thickness. And as you can see across healthy controls, relapsing, and other forms of MS, there really has been no large independent confirmation of this MTP cohort, but we're going to have to look out for it potentially as we move forward in studies of MS patients with OCT. And finally, there is microcystic macular edema, which is present in about 5% of MS patients. While it's not specific to MS or optic neuritis and is observed in other optic neuropathies, it is associated with increased disease severity by a number of measures. And moving forward, we're going to have closer studies to see how the presence of this microcystic macular edema might help us in our evaluation of the progress of MS disease activity. So I'm going to remind you that OCT is a novel tool to measure axonal and neuronal injury in the eye. It is vastly higher resolution than MRI, and its correlations through segmentation of the retina and the peripapillary region and through OCT angiography are providing us tools to help us in the management of the neuroimmunologic patient. Structural OCT is not helpful for optic neuritis diagnosis, but OCT angiography may be a novel method to classify optic neuropathies in the future. OCT may be a novel addition to our MS diagnostic criteria. And moving forward, OCT, as you've heard about, may provide us with prognostic information about vision after optic neuritis and inform us about MS disease activity. And I'd like to stop there and thank you all for your attention.
Thank you, Professor Bennett, for that informative and very valuable lecture. And I am sure that you will answer one or two questions if there's any. First of all, can I ask you whether OCT in neuroimmunology, like MS and NMO patients, can be used as a biomarker?
Well, I think that, yeah, I understand your question. I tried to bring in those elements where I think it can ultimately be used as a biomarker. We found the correlations between various elements of OCT segmentation and functional as well as disease activity markers in MS. What we have failed to do, at least in the monitoring of patients right now, is come up with the line in the sand, so to speak, that is going to be something that is actionable. And we need that amongst these biomarkers now to help us to determine in front of a patient that otherwise appears to be doing well, what can we use on the OCT scan to make an actionable decision that you may be meeting need a 3, so to speak, but things are not going right. Am I really going to, when you have no relapses, no evidence of new MRI activity, and no functional worsening in your disability, say, hey, we're not doing enough for you. And what are we going to do to up that ante? We need that sort of information, but we're on the way.
Thank you. So, thank you once again for your excellent.
This symposium is on CNS demyelination, and we have 3 eminent speakers who will be doing the talks during this symposium. And also, may I add that this is the team with which whom we work in our evaluation of patients with demyelination, with serous testing our patients and so on. So the first speaker is Professor Eoin Flanagan. Eoin is a professor of neurology working at Mayo Clinic on inflammatory demyelinating disorders. So he's going to talk on immune-mediated myelitis and its mimics. Over to you, Eoin.
Thanks very much for the opportunity to talk today. I hope you can hear me okay. I'm going to share my screen here. Perfect. Second here. And I'll just go back to the start here. It's a real great pleasure to be able to talk to you all at the SLCTRIMS, and it's great to see Dr. Sanyaki again. We had met at the American Academy of Neurology meeting many years ago, and Dr. Sean Piddock had set up a really great collaboration that has been very fruitful for about the past 10 years between Sri Lanka, where they have a great cohort of CNS inflammatory demyelinating diseases that we have been able to help with serology testing to really help figure out in a region of the world where we haven't got very many studies of how aquaportin 4 antibody disease and MOG antibody disease are in Sri Lanka. So these are my disclosures. They're not really too relevant to the talk today, the later talk, which will be on diagnosis. I'm going to start off with an introduction, just a little bit of background. So when we think about inflammatory demyelinating diseases of the central nervous system, I think it's important to distinguish between attack types and syndromes. So some of the attack types would include acute disseminated encephalomyelitis or ADEM, transverse myelitis, optic neuritis, or others, encephalitis, brainstem syndromes. And sometimes we have a combination of those. We have transverse myelitis, maybe longitudinally extensive, along with optic neuritis that we sometimes term neuromyelitis optica. And we can have combinations. We can have recurrent optic neuritis or recurrent transverse myelitis. But I think when we're thinking about the defined central nervous system inflammatory demyelinating diseases, it's important to think about the 3 major defined diseases that we have. So when we can't put it in a category of one of these 3 diseases, often use the terms on the previous slide. But I think the 3 defined diseases are multiple sclerosis and its spectrum, which would include relapsing remitting multiple sclerosis, primary and secondary progressive multiple sclerosis, or even radiologically isolated syndrome. And then I think the second well-defined and well-characterized disease is aquaportin 4 antibody positive neuromyelitis optica spectrum disorder. And the third is myelin oligodendrocyte glycoprotein or MOG antibody associated disorder, which we term MOGAD. So I think these are the 3 defined diseases that we have, and maybe we'll discover more in the future, but I think it's important to remember that these are the best terms to use. And when you mention neuromyelitis optica, it's important to mention the antibody in conjunction with that, because some patients with MOG antibody can also have an NMOSD phenotype. And if you were to qualify the seronegative group, MOG antibodies would account for some of those. So I'm just going to go over a little bit of some of the assays that we do here at the Mayo Clinic, and then I'll talk about a little bit about some of the great successes we've had from this collaboration. So the aquaporin 4 antibody, as many of you know, was discovered in 2004 by Dr. Lennon here at the Mayo Clinic. And this is a test that's best tested in blood. So blood is better than spinal fluid, is more sensitive. And with some of the older generation assays that we used to use, detecting by ELISA, we used to have some trouble with both false positivity, where the risk of false positives was 5 times higher, and it was also less sensitive. And what we've now recognized is that cell-based assays are optimal for the detection of aquaporin 4 antibodies. And indeed, in the diagnostic criteria, cell-based assays are recommended. And the sensitivity of our current assays are 80 to 90%, and the specificity is 99.8%. And this is just a study done. This was actually led by Dr. Waters at Oxford, Paddy Waters, in conjunction with Sean Piddock. And this was just a group of patients. Each row here that you can see highlighted is a single patient with NMO. And what you'll see here is that the initial assay that Dr. Lennon discovered this in 2004, we were probably able to pick up about half of all the cases of NMO. And subsequently with the ELISA assay, we made some excellent gains. But really with the cell-based assay, and the one we use is a live flow cytometry assay called a FACS assay, really we're able to pick up more of these cases. So when we've moved to the cell-based assay now, we're able to pick up 80 to 90% of cases listed as neuromyelitis optica spectrum disorder. So this really is a huge difference, because now you can make a diagnosis in 20 to 30% more patients. The aquaporin 4 antibody assay that we use currently is the live FACS assay. And here's an example of what we do here. So what we have is we have live cells in culture, and some of the cells are transfected with the aquaporin 4 on the surface. And this first sample at the top here is a negative sample. And then what we have is a positive sample here, where we can see that the binding to the receptor in these cells here, we use that, and then we divide it by the median fluorescence intensity in the cells that don't have aquaporin 4 on the surface, and we have a cutoff. And really this live cell-based assay gives us the best results here at Mayo, and this is what we've been using in collaboration with the Sri Lanka samples to analyze those. And recently we did a study just looking at our assay over the course of a couple of years in 1,371 patients. These were all Mayo Clinic patients, and we looked at all the positive samples. And what we found was that all of the positives were true positives. They all had a typical phenotype that we would expect with neuromyelitis optica spectrum disorder, and we didn't see any false positives. So really this aquaporin 4 assay is a really highly specific, great test, and you rarely encounter any false positives. We'll talk a little bit about the MOG, where the false positivity, there can be a little bit of an issue there. If we look at the MOG antibody assay, which is also a cell-based assay, is generally what is performed. Again, another study that Paddy Waters led in collaboration with Sean Piddock here at Mayo Clinic looked at a comparison of MOG antibody cell-based assays, and we looked at both live and fixed cell-based assays. And in this study, it was found that the live cell-based assays were performed slightly better than the fixed cell-based assay. And that led to an editorial saying that the live cell-based assays should be considered the gold standard. A subsequent international multi-center examination of the MOG antibody assay showed that there was excellent agreement for high positive. Here we can see over here for the for an example for the comparison of these studies, there was very good agreement for high positives, and for negative samples, but for the borderline results, there wasn't as good an agreement. And what we've recognized is that there have been some occasional false positives that we've encountered with the MOG antibody. So it's just something to remember. It's usually at low titer, and it might be because the glycoprotein is a little bit more sticky rather than the water channel, and therefore you may get some non-specific binding. What we do find is that the specificity is still very high, so it still has a 98% specificity. It's still an excellent test. But what we did in this study was we found that the positive predictive value was titer dependent. So if you had a very high titer of 1:1,000 in our laboratory, all of the patients had a typical MOG phenotype. On the other hand, if you had a borderline result at the 1:20 or 1:40, only 50% of those had MOG antibody-associated disease, and we saw in patients with multiple sclerosis or other neurologic conditions, we could sometimes see some low positive MOG antibody binding. So this is something important for people to recognize. And indeed, there's been another study done, which was done by a group in Germany, where they looked at the frequency of MOG antibodies in a large cohort of patients admitted to hospitals. So this was just any patient admitted to a neurology service, either a general neurology or stroke service, and they found about 1% admitted to neurology were MOG IgG positive. And again, they found that there was again a risk of low positive MOG antibodies in disease controls at a rate of about 1%, and these were usually low positives. So the message here is to be careful with your interpretation and potentially avoid testing in low probability situations where you think it's classic for multiple sclerosis. You may not need to test for the MOG antibody. So if we move on to the collaboration, Sean Piddock is my mentor here at the Mayo Clinic. I'm from Ireland. He's also from Ireland. We have kind of a bit of an Irish mafia going here at the Mayo Clinic. And he set up a great collaboration with Dr. Senanayake Binsara about 10 years ago, where we started getting samples from Sri Lanka in patients with CNS inflammatory demyelinating diseases. And so far, we've tested about 2,000 patients, and we test them all for MOG antibodies and aquaporin 4 antibodies. And Jessica Sagan is our research coordinator here, and Bimsara know her well. She's really an excellent person who helps coordinate all the shipping of these samples and has been kind of involved from the get-go also. And I think that the most important study that arose from this, and I will mention that currently I'm involved with a group that's creating diagnostic criteria for the MOG antibody-associated disease. And this study has been highlighted as being especially important, highlighting some regional differences in Sri Lanka compared to other regions of the world. And in this study, there was 726 consecutive samples from patients with CNS inflammatory demyelinating disease, and who we had clinical details available. And this was from the National Hospital of Sri Lanka. And it was over the course of 5 years from January of 2013 to March of 2018. And again, all of these patients were tested for the aquaporin MOG antibody by the assays I mentioned earlier. And the results in this study was interesting that MOG antibodies were found in 17%, or 126 of the 726 patients. And again, there was a high proportion of pediatric cases here. And we also found that many of these were of Sinhalese ethnicity. There was a more equal female to male sex distribution than we see with aquaporin 4 antibodies, where females predominate. And again, a little bit of a younger age cohort with many children, the age ranging from 3 to 68. And in comparison over the same time period, it was found that aquaporin 4 antibodies were positive in approximately 5%. So it seemed like MOG antibodies were 3.5 times more common. And that's a bit different what's been reported in other regions of the world, including in Japan, where the aquaporin 4, I believe, seems to be a little bit more common. The patients in this study, optic neuritis, which is the most common phenotype. I know you heard about MOG antibodies yesterday. Optic neuritis is the most common phenotype, but transverse myelitis was also common, ADEM a little bit less common, and then there was other combinations of presentations in this study. About 34% had a relapsing course. We know that MOG antibody associated disease patients can have a monophasic course in about half or over half of patients, and that was pretty common here also. And these patients were on a range of immunosuppressants, including prednisolone, mycophenolate, and azathioprine. About half of patients were on treatment. And overall, the outcomes looked pretty good. 94% had an EDSS of less than 6, and 74% had normal vision or only mildly impaired vision in 14%, while it was severely impaired in 12%. So overall, like we see with most MOG studies, the outcomes seem to be better with MOG antibody-associated disease than they are with aquaporin 4 antibody-positive neuromyelitis optica spectrum disorder. So I think this study highlighted, you know, an important regional difference here compared to other studies of MOGAD where aquaporin 4 has been higher, and the outcomes in the MOGAD Sri Lanka cohort were really overall pretty good. So I think there probably needs to be some further studies on this to determine whether the reasons for these regional differences of MOG antibody-associated disease prevalence across different regions of the world. This was another study looking at multiple sclerosis that was recently published in 2021 from the Sri Lanka group here, again with many of these patients tested by the serologies that we mentioned earlier. And they found a crude prevalence of MS was 7.78 per 100,000. And in this study, MS accounted for 15% of CNS inflammatory demyelinating diseases, which is very similar to what we found for MOG antibody-associated disease. In contrast, if we looked where I'm currently located in Minnesota, MOG antibody-associated disease, MS versus MS, MS would probably be about 50 times more common. So it's certainly quite interesting that MOG antibody-associated disease accounts for such a high proportion, as high a proportion as MS in this region. I'll just mention that this collaboration assisted with us in obtaining the first ever NIH Aura-1 grant on the MOG antibody-associated disease that I led here at Mayo Clinic. So this has been a really useful collaboration for us. And I'm expecting that there'll be further analysis of the aquaporin 4 antibody patients in Sri Lanka, and also we'll probably look into exploring more genetic and environmental differences. So that's kind of a summary of the collaboration so far. I think it's been really fruitful, and there's plenty more to come from that. I don't know if we want to stop there for questions, or should we move on to the lecture on immune-mediated myelitis and take questions at the end?
Yeah, you can move on, Eoin.
Okay, great. So now I'll switch gears and focus in on a topic that's quite dear to my heart, and that is immune-mediated myelitis and its mimics. So the goal here today is to understand the diagnostic approach to myelopathy and to recognize the utility of MRI in narrowing the differential diagnosis of myelitis. And as a disclosure, I am not a neuroradiologist, but I think I can show you some patterns that you can look out for that can help you determine and guide you towards the correct diagnosis. And to help you remember some of these patterns, you'll see some of these items scattered through the talk that can help you remember. So you'll hear about the trident sign, the flame sign, the pencil sign, the owl eyes, the snake eyes, the eye of Sauron, the TIE fighter sign, the Under Armour sign, the pancake sign, and the missing piece sign. So you'll see some of these scattered through the talk as I show you some of the ways we can look at MRI to remember the patterns and how they can help us with diagnosis. Just to mention, when we look at patients who are referred with a diagnosis of myelopathy or idiopathic transverse myelitis, it's pretty common that these patients are misdiagnosed. Indeed, in a study that we did at Mayo Clinic, where we looked at patients who were diagnosed with idiopathic or an unknown cause for their transverse myelitis, a specific diagnosis was identified in 70% of those patients. So it shows you that this is a big problem. And there has been many studies showing that there's overlapping features between inflammatory myelitis and non-inflammatory myelopathies that sometimes can lead to misdiagnosis. So we'll focus in on some of those diagnostic pitfalls through this talk. So when we think about evaluating myelopathy, something I'll mention on the next few slides is the time from the onset of symptoms to the maximal deficit, because this is really key to helping you stratify your differential diagnosis. So one of the most important things is getting a good history of the onset of symptoms. We also use MRIs of the brain and spine when we're evaluating myelopathy. And the first step in evaluating myelopathy is to exclude an extrinsic cause. Here we see degenerative disc disease and compression of the spinal cord, which is a spinal neurosurgical emergency. So we always want to identify that early on. But we'll focus today mostly on patients with lesions within the spinal cord or intramedullary involvement of the spinal cord. It's also important to remember that sometimes your brain MRI can help you if you see many lesions suggestive of MS like we see here. It might tell you what's going on within the spinal cord. And just to mention here that the CSF can also be useful. We use the CSF to look for inflammatory cells. We also use it to look for oligoclonal bands. That can be a marker of multiple sclerosis. And we also can use the CSF to look for infections or to look for cancer cells. So CSF analysis is going to be key in every patient with myelopathy. We mentioned earlier these blood antibody biomarkers. Before we had these antibody biomarkers, it was more difficult to make a diagnosis for patients with myelitis. But now with these available, we've been able to improve, and now in 10 to 20% of patients, we can make a diagnosis where we previously were not able to make a diagnosis. So your aquaporin 4, your MOG antibodies, and there's some other antibodies that we'll talk about also. And then infectious testing is going to be important. In the United States, in the Colorado region, we've had outbreaks of acute flaccid myelitis in association with enterovirus infections, and there may be other infections endemic in Sri Lanka that might be important to think about. So this is the general approach, and we'll focus in mostly on these first two sections here through this talk. So the first thing to mention is the time to maximal deficit. And if you remember anything from this talk, I would say this is one of the key points to remember. And this is really key in myelopathy diagnosis. So if you have a patient with a very severe myelopathy that comes on over the course of a few hours, 4 to 6 hours, or less than 12 hours, you're really going to be thinking about a spinal cord infarct. Now, patients, if they have a functional neurologic or conversion disorder, they may present that quickly also. But a hyperacute onset, you really want to be thinking about a spinal cord infarct. And these patients are usually very severely affected, so it's usually paraplegia or complete paralysis of the legs, or complete paralysis of the arms and legs, or quadriplegia. When we think about the term transverse myelitis, that's an inflammatory condition that can be associated with infections, but also is synonymous with demyelinating conditions like aquaporin 4 antibody positive NMOSD and MOGAD, and also we can have a myelitis with multiple sclerosis. And that usually reaches its maximal deficit between 12 hours and 21 days. So it's a slower onset than this hyperacute, but usually it reaches its maximal within 21 days. So if you have a patient progressing beyond 30 days, then you really want to think away from a diagnosis of transverse myelitis and into a broader differential diagnosis, many of the conditions that are outlined here. It can occur with demyelinating disease in the form of primary progressive MS, but then you want to be considering your dural AV fistula, spondylosis, astrocytoma, nutritional deficiency, other inflammatory conditions, sarcoid, paraneoplastic. We'll cover some of those today. Also degenerative conditions, HSP, hereditary spastic paraparesis, and ALS. So really use that time to the nadir to help you in stratifying your differential diagnosis. Just to mention briefly about spinal fluid, if you have a patient where you do a spinal fluid and the white blood cell is normal and there are no oligonucleotide bands, you should at least stop and think, could this be a non-inflammatory myelopathy, something like a spinal cord infarct, a dural arteriovenous fistula, spondylosis, tumor, nutritional deficiency. Sometimes inflammatory conditions, it can be normal. You want to be careful. If you see that, that might be a red flag against an inflammatory etiology. On the other hand, if you see an elevated white blood cell count or oligoclonal bands, it might point you more towards some of these inflammatory etiologies that we mentioned here, or an infectious etiology. But sometimes with non-inflammatory, like with the spinal cord infarct, you can have a few white blood cells leak into the spinal fluid. So don't let that completely exclude it for you. If you see a markedly elevated CSF protein and a normal cell count, you want to consider, could it be a spinal block? Sometimes you get prevention of recirculation of protein, and that results in an elevated protein. Also, you might want to reconsider, could this be albuminocytologic dissociation, and could it be a Guillain-Barré or a peripheral nervous system condition? And then if you have reduced glucose, that usually suggests meningeal involvement. And sometimes we see that with neoplasm. We can see it with sarcoid meningeal involvement, although we don't see it as much when the sarcoid just involves the parenchyma. So when we're thinking about the MRI in a patient with myelopathy, one of the key things to remember is the lesion length with a cutoff of 3 vertebral segments. So here we can see a lesion that extends more than 3 vertebral segments. You see 1, 2, 3, and this is more. And this is what we term a longitudinally extensive lesion. And sometimes that's put together with transverse myelitis to be called an LETM. And this is what we typically see with aquaporin 4 antibodies, with MOG antibodies, but there are other etiologies as we'll talk about later. On the contrary, if we have a shorter myelitis lesion extending less than 3 vertebral segments, MS is going to be the most common cause of this. So use this 3 vertebral segment cutoff to your advantage. Now, sometimes the timing can influence this T2 lesion length. So if you do an MRI very early in the course, here's an example of a patient who had an MRI after day 1. They presented with vomiting, but then developed myelopathy symptoms. And after 2 days, the lesion is extending over 2.5 vertebral segments, and after 12 days, it extends over 3 vertebral segments. But early on, you may miss a lesion in evolution. On the contrary, if you image someone many months after their myelitis, this longitudinally extensive lesion may have recovered and now may become more discontinuous or late. The other thing to mention is that the lesion length is related to the acute myelopathy episode. So sometimes with MS, in a chronic patient with MS, you can see this kind of diffuse T2 hyperintensity. This is a patient outside of an attack with progressive MS. And that's not what we're talking about. We're talking about an acute lesion at the time of an acute attack. So just be careful. In the chronic setting, we're not talking about lesion length because sometimes MS can look like that in the chronic stages. The axial location is also important. So here we can see an example of a central lesion within the cord that we typically see with neuromyelitis optica, for example. Here we see a peripheral lesion. Here we can see a lesion typical of MS involving the dorsal columns on the left here. Here we can see a more central gray matter lesion. We'll talk a bit more about this later. We can see this with MOG antibodies, or we see it with acute flaccid myelitis. See involvement of just the anterior horn cells here in this owl eye or snake eye pattern that's consistent with ischemia. And then sometimes we can see dorsal or lateral column signal extending over multiple vertebral segments in things like vitamin B12 deficiency, where you get sub-combined degeneration of the cord. So I think when you're looking at your axial images, you want to look out for these patterns on the T2 weighted images to see if it falls into one of these patterns. And I think with our MRI machines nowadays, you can kind of put it into one of these categories. So if we combine the length of the lesion with these categories, then you'll see what I mean here. So here you see an example of an MS case with a short lesion extending about 1 vertebral segment here. And then it involves the cord periphery here in the dorsal columns. And MS lesions are short, less than 3 vertebral segments in 99% of cases. So that's very, very useful feature. With MOG antibody-associated disease, we can sometimes see short lesions, maybe in up to 30%, often involving the conus, like we can see here. And they're often central on axial images. It didn't project too well here, but that was central. With aquaporin 4 antibodies, in about 15%, it can be short. So a short lesion does not exclude aquaporin 4 antibodies. Here we see a large, swollen, but short lesion extending 2 vertebral segments. And on the axial images, this one is central. Again, the central on the axial might be a clue arguing towards the aquaporin 4. But more typically with the MOG and the aquaporin 4, we'll see a longitudinally extensive lesion like we see here that's central on the axial images, okay? So that's pretty typical with the MOG and aquaporin 4. But for example, if we had a patient with vitamin B12 deficiency, we see this long lesion within the dorsal column. So we see it extend along the dorsal columns here. So combining the length of the lesion with your axial location is going to be very helpful in determining what the etiology of the myelopathy is. And if I was to poll the audience here, I have about 10 different longitudinal extensive lesions here. And if I was to say to the audience, what are all of these? They would say they're all aquaportin 4 or MOG maybe. But actually there's a wide variety of different etiologies scattered across this image. And what I'm going to show you over the next many slides is that the gadolinium enhancement pattern, so when you give the contrast, the pattern of enhancement that you see can really help you narrow the differential diagnosis. So we'll come back to this slide later, and I'll show you when you add the post-gadolinium images how that is helpful. So if we think about the lesions with aquaportin 4 antibody positive NMOSD, myelitis, these are usually severe episodes, so patients, not uncommon for a patient to be wheelchair dependent after a severe episode or after an episode of myelitis with aquaportin 4 antibodies. And the myelitis is usually isolated, but sometimes it can occur in conjunction with area post syndrome. Patients have intractable nausea, vomiting, or hiccups, or it can occur in conjunction with optic neuritis. Be careful if the aquaportin 4 antibody is negative, because there are many other causes of longitudinal extensive lesions. There are some features of the T2 signal that can help you. Here you see a longitudinal extensive lesion, and then we see this bright spotty T2 area within it that is typical of aquaportin 4 antibodies. Sometimes we can see T1 hypointensity like we see here. And we can also sometimes see ring enhancement. So here we see an example of somewhat of an elongated or ring of enhancement. Or here we see a more obvious ring of enhancement here, or an elongated lens shape enhancement here. And on an axial image, see this ring of enhancement. We can also see ring enhancements with MS, but it tends to distinguish well from other causes of long lesions that we'll talk about later. So you can think of this as your Eye of Sauron type picture. With MOG antibody disease, children are particularly predisposed, so they account for about 50% of cases of MOG antibody associated myelitis. And again, this can occur in conjunction with optic neuritis or in conjunction with ADEM as a component of ADEM. And sometimes it can mimic these acute flaccid myelitis that we see with enterovirus. And what we can see here is that these tend to be not quite as bright. So sometimes we see this long segment of signal abnormality, and sometimes we can see this sagittal line on the sagittal images. Here we see another example of a long lesion within the thoracic board. And then on axial images, in probably a third of patients, the T2 signal is restricted to the gray matter. Rather than being central and diffuse, it's more restricted to the gray matter. And that can be a useful sign to look out for. Also, just to mention that you may have a patient with a long lesion and then a separate short lesion. So when you have multiple lesions, a long and a short, that's going to be more suggestive of MOG antibodies. With the aquaportin 4, it's usually just a single longitudinally extensive lesion. And then we can have involvement of the conus, is pretty typical of the MOG antibody disease. So if you have involvement of the conus, you want to think about MOG antibodies. And we talked a little bit about the low positive MOG antibodies and the potential for false positivity. And this H sign that we see here, you can think of this as your TIE fighter from Star Wars, or as your Under Armour sign, like we see here. So this H sign is quite useful to look out for. But some patients do have more diffuse T2 signal, and it's hard to distinguish from aquaportin 4. We don't tend to see this H sign as much in the aquaportin 4 cases. So what about the importance of spinal cord? Well, I'm a big believer that the spinal cord is very important in CNS demyelinating diseases, and I'll show you why over the next few slides. So firstly, what we know is that patients with CNS demyelinating diseases, if they have an upper cervical lesion, this can be potentially life-threatening. And we know that historically patients with aquaportin 4 antibodies, before we had good treatments, and when many of these patients were treated as MS, it was pretty frequent that these patients could present in the hospital with respiratory failure from an upper cervical myelitis. Now, we recently looked at this amongst patients at Mayo Clinic in more recent years, and we have found that that seems to be less frequent with the available treatment. But that still is a possibility. So a single attack could lead to respiratory failure and even death in some patients. The other thing to mention is that the episodes of myelitis, particularly with the aquaporin 4 antibody, can be quite severe. And here you see a patient who's had multiple myelitis episodes, and they have very little spinal cord left here, and it can lead to irreversible paraplegia, particularly untreated. So it's really important to treat the aquaporin 4 antibody attacks and to get patients on attack prevention treatment, because in the past we were seeing these really destructive episodes with patients left paraplegic with very little spinal cord left. Another thing to mention that is interesting, that we have taken an interest here at Mayo Clinic, is a terminology called progressive solitary sclerosis. So we know that patients with multiple sclerosis, by definition and by the diagnostic criteria in general, have to have more than one lesion. But there are some patients who have MS who have hundreds of lesions, and there are other patients who just have a couple of lesions. And what we've recognized is there are some patients who look very like MS, but they just have one lesion, and they may progress from that lesion. And here's an example of a spinal cord lesion here, a short lesion. Patient developed progressive atrophy of the left lateral column here, along with progressive left arm and leg hemiparesis. So you have a single lesion here. This patient has positive oligoclonal bands. It looks classic for MS, but they don't have any other lesions. So they are termed progressive solitary sclerosis. We think this is along the MS phenotype, but it's interesting to think that one lesion can cause progression, because in general, it's thought that it's a diffuse neurodegenerative process, but what I would argue is that the lesion location is quite important. And here I'll show you an example of a case. This is a case from a group of patients where we looked at unilateral progression from a single MS lesion. So this patient presented with a myelitis, with left-sided weakness of the arm and leg, and you can see an acute lesion here. And here we can see it in the left lateral column. We can see a ring of enhancement. We talked about that earlier, that we can see with MS or aquaporin 4 antibodies. And again, a ring here. And many years later, 5 years later, this patient began, after they recovered from their myelitis, began to develop slowly progressive left hemiparesis. And here what you see is that the lesion has become somewhat more atrophic, and we can see some atrophy with loss of the rounded appearance that we see typically in the spinal cord on this other side. And that's associated with this progressive left hemiparesis. Now, this patient has many other lesions in the brain here that are likely not causing any symptoms. We can see some here at the inferior temporal pole and in the cerebellum. And this led to a couple of editorials that were titled Location, Location, Location. So having a demyelinating lesion along the lateral columns or at the cervical-medullary junction can be quite problematic and probably disproportionately contributes to disability. And the fact that one lesion in the spinal cord can cause disability just shows you how important the spinal cord, because all the fibers from the brain converge on the spinal cord. You can see in this small area, there's many fibers that can be damaged. Another thing that we've had interest in recently is lesion evolution. So when we look at the MOG antibody cases, here we see a case with longitudinally extensive lesion, and here we see this H sign. And then in follow-up a couple of years later, this lesion had resolved completely. So we see complete resolution of the lesions in MOG quite frequently, actually. Probably the majority of MOG antibody cases, the lesions tend to resolve. On the other hand, with aquaporin 4, we see a very severe lesion here in the thoracic spine, and we see, again, a little bit of atrophy. We didn't seem to see much atrophy here. And then we can see this residual scarring or residual signal abnormality within the cord here. And then with MS, again, here we see a typical MS lesion, and we see that the MS lesion does not go away and it leaves a scar. And of course, we know that that's the case because we tend to image patients with MS, even if they don't have attacks, to look for evidence of new lesions that have accumulated. And that's based on the principle that MS lesions tend to leave a scar and tend to persist over time. The enhancement goes away, but the lesions persist. And one could argue that it may be these lesions that are a nidus for future progression in MS, because we don't see a secondary progressive course with the MOG antibody. So if we think about the MOG antibody, we might have a monophasic course where if we have EDSS on our y-axis and time on the x-axis here, and what we can see here is the patient comes in with a myelitis episode, has a severe episode, maybe paraplegic, but then can recover completely. and then never develops any progression and never develops any further relapses. Or the patient may have multiple relapses, but when they do, they tend to recover well from them. And this follows the radiology, that the radiology often resolves very well. And these patients develop minimal disability with each attack. They do develop a little bit of disability, so it is going to be important to prevent MOG antibody disease attacks, but it tends to be mild disability, just like the study I showed you from Sri Lanka, where the disability was fairly mild. This differs from aquaporin-4 antibodies, where we can see here patients will have a severe event and maybe be paraplegic, but after one attack, they tend to be left with some residual disability. So they may be dragging one leg after one attack of myelitis. They may be using a cane after 2 attacks, using a walker after 3 attacks, and in a wheelchair after 4 attacks. So again, they tend to have poor recovery. Thus, it highlights how important it is to get in with treatment here to prevent this, ensuing disability, and also to try and treat with plasma exchange to bring down the severity and increase the chance of recovery with these attacks. With MS, here we can see with the EDSS here, we see a milder attack with MS. So they may just have some mild sensory symptoms and they tend to recover pretty well. But what I would argue is it may be that some of these scars that are left over contribute to this progressive phase, or patients with MS can have just a primary progressive phase. Again, with the aquaporin-4, we don't seem to see this progressive phase either. So I think we can learn something from the radiology, and at least we can speculate that that might be contributing to some of the disability. I'm going to talk about some other inflammatory and non-inflammatory myelopathies over the next many slides. And we'll just see how we're doing for time here. So here we can see a patient with a longitudinally extensive lesion within the cervical cord. And then we can see this dorsal subpial enhancement. Here we can see in the axial image this subpial enhancement. Another example here, and this is very typical of sarcoidosis. And here, sometimes you'll get a clue on your MRI of the thoracic spine. You can see these bulky hilar and mediastinal lymph nodes here. But if you see this pattern, you really want to think about sarcoidosis as the most likely etiology. Another thing to mention about sarcoid is that even when you treat patients with steroids, prolonged steroids, you can see here this enhancement in the dorsal subpia, and the enhancement tends to persist over time. Here at 2 months, it's still there despite treatment. At 5 months, it's still there and eventually resolves. While with the aquaporin-4 antibody, here example, we see that the enhancement tends to go away in 95% within a couple of months. So if you see persistent enhancement ongoing on your MRI beyond 3 months, you want to think about potentially sarcoid or some other etiologies. Now here's an example of another of sarcoid. So here we see a longitudinally extensive lesion, and then we see this enhancement in the dorsal subpial area here. And what we see here also is some central canal enhancement. So we see this kind of 3-pronged appearance. And we thought this had a kind of 3-pronged appearance. And we actually sent this to the journal Neurology. And the editors sent it back to us. And they said they squinted and they stared at these images, but they couldn't see this 3-pronged trident appearance. So at the suggestion of Brian Weinschenker, one of our colleagues here at the Mayo Clinic, we traced it around for them like this. And then we sent it back to them, and they agreed to publish it. So the trident sign, sometimes we see this central canal enhancement. This is also a marker of sarcoidosis, but the dorsal subpial is going to be more common and really the very useful finding. But if you see the trident, you want to think about sarcoidosis. Another antibody that we've recently recognized can be associated with spinal cord involvement is antibodies to GFAP, glial fibrillary protein, which many neurologists will be aware of. And this was discovered by Dr. Lennon here at the Mayo Clinic. And what they recognized is there was patients who presented with encephalomyelitis. So it was not usually myelitis on its own, but usually an encephalomyelitis or encephalitis on its own, where you would see this radial enhancement in about a third to half of patients. That was very striking in this situation. And some of these patients can have kind of hazy T2 hyperintensity and sometimes some central canal enhancement. And this can be associated with teratoma and tends to be quite steroid responsive. And it's best tested in spinal fluid. We can also see paraneoplastic myelopathies. So these again tend to be longitudinally extensive. And there's a useful imaging finding here where you can see this enhancement And then on the axial images, you see this tract-specific enhancement, most characteristically along the lateral columns. So if you see bilateral tract-specific enhancement along the lateral columns, that's going to be suggestive of a paraneoplastic myelopathy. And the antibodies that we think of are CRIM5 or anti-CV2 or amphiphyssin antibodies. And we think about breast cancer and lung cancers as the most common cancers. Another sign that you can look out for is the rim and flame sign. This was studied by our neuroradiologist here at the Mayo Clinic. And here you see a flame at the top of the lesion and at the bottom of the lesion, and then a rim of enhancement with a less enhancing center. And sometimes in that center, you can see a dot sign. So this rim and flame and dot sign have been reported as suggestive of intramedullary spinal cord metastases. That's cancer spreading to the intramedullary part of the spinal cord. Most cancers, when they present, they compress the cord from externally. But when you have intramedullary involvement, think about this rim and flame sign and the dot sign. Another disorder that is commonly mistaken for transverse myelitis is spinal cord infarction. And sometimes with spinal cord infarction, you can see this pencil sign, where you see this linear signal abnormality within the anterior surface of the cord here on sagittal images. And on axial images, you'll often see this owl-eye pattern, where the anterior horn cells, which are the most vulnerable to ischemia, light up brightly on T2-weighted images. Or sometimes this was the same patient, it looked like an owl, and then later looked like a snake eye appearance from that selective vulnerability of the anterior horn cells. Sometimes, about 5 to 10% of the time, you can see a vertebral body infarct, which is very helpful, because these are hard cases to diagnose. And when you see that, that suggests that the blood supply that supplied the spinal cord also supplied the vertebral body. We could also see a linear strip of enhancement within the spinal cord that we can see with spinal cord infarction. Here we can see an example of restricted diffusion here within the dorsal spinal cord, which is a useful imaging feature also to suggest infarct. A dural arteriovenous fistula is a do not miss diagnosis for neurologists, commonly mistaken for transverse myelitis. And what you'll see is that these patients tend to have more of a progressive myelopathy, 30 days that we mentioned, and they can get worse with steroids. And we'll often use a spinal angiogram to diagnose these, a formal spinal angiogram, and they can be treated with ligation of the blood vessel, or they can be treated endoscopically during the angiogram. And one of the key features is these flow voids that you see dorsal to the cord. But really, any patient with a longitudinally extensive lesion within the thoracic cord, you want to think about a dural AV fistula. Sometimes you'll see some enhancing veins. And one of my colleagues at Mayo Clinic mentioned that sometimes you'll see this missing piece of enhancement within a long segment of enhancement. So that's suggestive of the dural AV fistula. Another pattern that was recognized by Dr. Brian Weinstecker here at the Mayo Clinic is the pancake sign. So what we know is that with cervical spondylosis, in about 15% of patients, you'll have T2 signal abnormality. But in about 7%, you can see associated enhancement. And the enhancement tends to form this transverse band where the width is greater than or equal to the height. Usually with transverse myelitis or inflammatory etiologies, the enhancement will go all the way through the lesion. So if you see this fine transverse band of enhancement, and on the axial images, it's called the pancake sign. And on the axial images, it tends to spare the central region. So it involves the circumferentially the white matter. And it can even persist after surgery. We think it's related to breakdown of the blood-spinal cord barrier and can persist after surgery for many years. And sometimes that leads to confusion from our neurosurgeons. But if you see this pattern, think about it being caused by spondylosis, and they need surgery to fix their spine. So you might say, well, I've talked about many enhancing patterns, and can these really be useful in real life? If we had a neurologist or a radiologist and we trained them on these patterns, could they recognize them? And what we did was we did a study, and we had 113 different cases of long myelopathies, where many of them where these patterns were present and some controls where they were not. And 74% of these patients received the wrong diagnosis. And we had a neuroradiologist and a neurologist who were educated on the patterns. And what they found was that they were able to identify the correct diagnosis much more frequently when they had the post-gadolinium images added to the T2 weighted images. So on the T2 weighted, they were able to detect it in 50 to 60%, but up to 90% almost after post-gadolinium. So it's worth recognizing these patterns because they can be really useful in diagnosis. So what I'm going to do now over the next many slides is summarize some of these patterns, and then we'll come back to some of the cases that I showed earlier. So your MS is going to be a short lesion on the T2 weighted image, usually in the dorsal or lateral column. With ischemic lesions, you will have anterior involvement, sometimes with this owl eye or snake eye appearance, and then you can have involvement of the vertebral body also. With spondylosis or sarcoid, you'll just have a long lesion that will be central. It's difficult to discriminate. With the aquaporin 4, you'll have this long lesion that you see here, sometimes with this bright spotty area within it that looks like a syrinx. With paraneoplastic, you may have this signal abnormality that extends along the lateral columns. Nutritional deficiency, you may have this along the lateral and dorsal columns. And then if you have anybody with a long lesion within the thoracic spine, you want to be thinking about a dural AV fistula, and you may see these flow voids in association. And MOG antibody myelitis can have long lesions and often involves the conus, and sometimes you have this H sign, as we mentioned earlier. And then with GFAP, it tends to be a more hazy T2 hyperintensity. If we summarize some of the enhancement patterns again, here we can see this homogeneous or ring-like enhancement that we see with multiple sclerosis. With ischemic lesions, we can have this anterior enhancement or enhancement in the vertebral body related to the vertebral body infarct associated with it. With paraneoplastic, we can see tract-specific enhancement going along the lateral columns. So you want to think about your CRIMP5 or AMPI5 antibody. With spondylosis, we can see this transverse band of enhancement. Again, on the axial images, this is the pancake sign, where it spares the central region and extends around the outside of the cord. Or with sarcoidosis, we have this dorsal subpial enhancement, sometimes with central canal enhancement, forming a trident sign. And then with the aquaporin 4 antibody, we see this elongated ring of enhancement here, or sometimes we just see patchy enhancement with the aquaporin 4. And then with dural AV fistula, we may see a missing piece of enhancement or some enhancing veins. And then we talked about the intramedullary metastasis, where we see this rim of enhancement with a flame at the top or the bottom. Again, a rim of enhancement, sometimes with the dot sign. And then with GFAP, we can sometimes see central enhancement. And with MOG antibodies, we didn't discuss this in detail earlier, but up to half of cases will have no enhancement, or if they do have enhancement, it's very minimal. So that's one to think about if you see no enhancement. And then we also think about the persistence of enhancement. As I mentioned, after a couple of months, the demyelinating conditions, so MS, the aquaporin 4 and the MOG, the enhancement tends to go away. And then we're left over with conditions like spondylosis, sarcoidosis, dural AV fistula, paraneoplastic, and intramedullary metastases. So if we come back to the initial image and we look at these cases, so here you see this first case, and we see we had this long lesion here, difficult to tell what that was, but with the post-gadolinium images, you see this transverse band of enhancement sparing the central region on axial images. So this was the pancake sign and cervical spondylosis. The next two cases, we have two long lesions, but here you can see this linear dorsal subpial enhancement and linear dorsal subpial enhancement with central canal enhancement that was consistent with sarcoidosis. Here we see another example of a long lesion, again with an enhancing rim with a flame at the top or the bottom. This is your intramedullary metastasis. Here we have a long lesion within the thoracic cord. We're going to be worried about a dural AV fistula anytime we have a long lesion here. And here you can see this missing piece of enhancement that was consistent with the missing piece sign and dural arteriovenous fistula. Here we see another example of a long lesion within the cord. This was a patient who developed quadriplegia over the course of a couple of hours. And here you can see the anterior horn cells with this owl eye pattern. And again, on the enhancement, this linear strip of enhancement with enhancement again in the anterior horn cells. This was consistent with the owl eye sign and spinal cord infarct. Here we see a long lesion along the cord, again with enhancement, but this time the enhancement is involving the both lateral columns, which is highly suggestive of a paraneoplastic myelopathy, these tract-specific enhancement along the lateral columns. And then here we have a long lesion with this H sign involving the gray matter and not much enhancement on the postgadolinium. And this was MOG antibody-associated disease, the TIE fighter or under armor sign. And then finally, we have the aquaporin 4 antibody case here, where we see a long lesion with the bright spotty area in the middle. There was a slight clue on the T2 weighted image. And then we can see this elongated ring of enhancement suggestive of the Eye of Sauron, and this was aquaporin 4. So you can see here that the postgadolinium images here really help to determine what most likely diagnosis might be. It can help guide your tests. It can help you if you are not sure of the diagnosis in how you might treat it. So I think it's quite useful to think about some of these enhancement patterns. So I'll stop there. I'd like, in addition to acknowledging my colleagues from Sri Lanka, I'd also like to acknowledge many of our group here at the Mayo Clinic, including Dr. Chen, who works closely with us in the area of neuroophthalmology and MOG antibody disease. And it's a great pleasure to be able to talk in the same session with him and Dr. Dubey. And this is all our group here at the Mayo Clinic Neuroimmunology Lab who help us do all these tests for the aquaporin 4 and MOG antibodies that you are also kind to send us that we can work up. So I'm going to stop there and I'll open it up for questions. Maybe I'll stop my share here.
Thank you very much, Eoin, for that excellent presentation, helping us to sort out myelopathy and myelitis, giving us many tips and clues. Yes, the session is now open for any questions. Can I just start asking you about the resolving lesions you mentioned in MOG disease? What was the phenotype in those cases? Was it ADEM-like phenotype?
It seems to be consistent across all phenotypes. So if a patient, we looked in the brain and the spinal cord, and I would say the majority of patients, the lesions resolve, which is not the case with MS. So what we know is that when we see a patient with ADEM, they may have 25 different lesions, and if you image them and follow up a couple of years later, oftentimes the vast majority are completely resolved. And with MS, if you have 25 lesions, you'll be able to see 23 or 24 of them. So it's any phenotype. We don't really know why that happens. It may be that there's enhanced remyelination is one thought. There may be reduction in edema, but it does seem to be different than MS. And I think it does give us some insight into the different pathophysiology and pathogenesis of MOG antibody disease.
And also, can I ask about GFAP encephalomyelitis? I think we have also sent you a few CSF samples. Now, yesterday, Professor Fujihara was talking about GFAP in serum to monitor patients with MS. So this, now here we had to do the CSF analysis, right? Is it the same thing?
Yeah, so it's different. No, it's different. Yeah, so I think what Dr. Fujihara was talking, Professor Fujihara was talking about was GFAP as a damage biomarker, not the antibody. So this is just measuring GFAP itself. And we know that aquaporin GFAP is part of the astrocyte. So aquaporin 4 attacks the astrocyte, and therefore when you get astrocytic damage, you're going to get some increase in GFAP in the blood. Just like in MS, where we see some increase in serum neurofilament light. But what we also know is that there can be an antibody targeting the GFAP that is associated with this clinical syndrome. So, and actually, it's interesting that you mentioned that, because with neurofilament light, we also have an antibody to neurofilament light that's associated with neuroendocrine cancers and can be associated with different phenotypes. So it's important to think about the biomarker of the damage biomarker itself, and then an antibody to it. If that makes sense.
Any further questions? One more question about these lesions in the spinal cord, like with your excellent description. I think we should be able to narrow down the diagnosis, but in some cases, in spite of all that, you might still not have a diagnosis. Is there a possibility of doing biopsies for these lesions?
There is, yes. So here, and I don't know, resource-wise, here at Mayo Clinic, some of the that have helped us was, for example, a PET scan. With sarcoidosis, a PET scan is quite useful to detect lesions within the lymph nodes, and then we can target those and biopsy them, because we never really want to biopsy the spinal cord. But before we recognize this pattern, we would actually often go in and biopsy the spinal cord, and you know, you would find non-caseating granulomas. But what I would say is that for that example with sarcoidosis, which is going to be one of your more common ones, if I see that pattern, my tendency would be to treat the patient as sarcoidosis and only do the biopsy if your treatment is not working. Because I have seen some cases who had a kind of similar pattern, who had astrocytoma, but I would say 99% of the time we're right and the pattern holds up. But, you know, like everything in medicine, you can never say never say always, kind of thing. So the spinal cord biopsy can be done safely. The main thing would be, you know, if it's a neoplasm, if you're thinking about lymphoma, astrocytoma, but sometimes we'll empirically treat and try and avoid that as best as we can. Yeah.
Thank you very much. I think now we can move on to the next lecture. I would ask my co-chair to.
Hello, and our next lecture will be interesting, and the topic is the neuroophthalmology in CNS-IDDs, an update. It's done by Chen. So over to you, John. Thank you.
Great. Thank you so much for the invitation to speak here. And I'm a neuro-ophthalmologist at the Mayo Clinic, working with Dr. Dubey, Dr. Flanagan. And today I'm going to focus on optic neuritis and CNS demyelinating disease. So we had a wonderful talk from Dr. Flanagan on the myelitis and spinal cord kind of changes that can occur. I'm going to switch over gears and talk about my favorite topic, optic neuritis. And it's really my favorite topic because of the amazing advances we've had over the past couple of decades in having biomarkers for atypical optic neuritis with aquaporin antibodies for NMO, MOG antibodies for MOG, antibody-associated disease, where it not only changes the prognosis, but more importantly, it changes the treatment, the way we actually approach these patients. And so I'm, in terms of disclosures, I'm a consultant to Roche and UCB, but that won't have any relevance to this talk. And we'll talk about some off-label immunotherapy for MOGAD. We're going to compare and contrast optic neuritis from multiple sclerosis, NMO spectrum disorder, and MOGAD. And we're going to review the treatment of optic neuritis in these CNS demyelinating diseases. So just as a background, I'm sure all of you know, optic neuritis is an inflammation of the optic nerve, and it's the most common cause of optic neuropathy in a young patient. And patients classically present with subacute monocular vision loss. Usually the vision drops for several days before reaching its nadir. Oftentimes patients have pain with eye movements. The described colors aren't quite as vibrant as they were with this dyschromatopsia. And when we look in as ophthalmologists, 2/3 of the time, the optic nerve is actually normal because it's a retrobulbar optic neuritis. And if there is disc edema, it's typically mild, similar to this patient here with this grade 1 disc edema. Because again, usually more the inflammation is more retrobulbar. And that's important. That's for typical optic neuritis. We're going to talk about some atypical causes of optic neuritis where you have more profound disc edema. A lot of what we know about optic neuritis, we still quote from the optic neuritis treatment trial, which is now over 30 years old, published in February of 1992 in the New England Journal of Medicine. And what it told us is that optic neuritis tends to get better. It typically improves over 1 to 3 months after a bout of optic neuritis, and 92% of patients improve to 20/40 or better, with only 3% of patients with a vision of 2200 or legally blind or worse. What the New England, what the optic neuritis treatment trial also showed us is that IV corticosteroids, high dose, led to faster recovery, but did not actually change the ultimate outcome. And surprisingly, a low dose oral prednisone led to an increased recurrence rate. But it was interesting because before the optic neuritis treatment trial, it was thought that IV steroids would lead to better outcomes, but really it found in this randomized clinical trial that all it did was speed recovery for typical optic neuritis. And that's what's important for typical optic neuritis. And what I mean by typical optic neuritis, that's going to be mostly your patients with multiple sclerosis or idiopathic optic neuritis. And so in the framework of mind, at least in the Western world where we've got such a high prevalence of multiple sclerosis, when we think typical optic neuritis, we kind of equate that to our MS patient. So it's going to be a young adult female, Caucasians affected more than Black and Asians. Patients usually have mild to moderate vision loss, and they usually have good recovery. As I mentioned, only a third have biscademia, and if it's present, it's typically mild. And of course, with MS, you get these periventricular white matter lesions. There's that strong association between optic neuritis and MS, especially in the Western world, where 50% of patients with optic neuritis will develop MS. And optic neuritis is the presenting symptom of MS in 25% of the time. And if you have MS, you develop optic neuritis at 50% at some point in the disease course. And again, this is what we think of when we think typical optic neuritis. This is the predominant patient in the optic neuritis treatment trial. But we now know, of course, the optic neuritis treatment trial finished in in the 1980s or 79. What we now know is that we've got these other demyelinating disorders. We've got aquaporin 4 positive NMO. We've got MOG antibody associated disease. And unfortunately, the optic neuritis treatment trial does not tell us much about these disease entities. We recently went and had the original serum from 177 patients from the optic neuritis treatment trial, and we checked the serum for aquaporin 4 and MOG, and 0 patients were positive for the aquaporin 4 antibody, and only 1.7% of patients were positive for MOG antibodies. What that means is that the optic neuritis treatment trial, the ONTT, provides excellent details for multiple sclerosis and typical optic neuritis, but not for NMO and not for MOGAD. So what do we know about NMO and MOGAD optic neuritis? Well, let's talk about NMO first. I'll just start off with a classic case of how NMO tends to present. This is a 36-year-old African-American female that we saw in our clinic. She had a history of optic neuritis in the right eye with poor recovery, and now she's presenting with severe vision loss in the left eye with eye pain. She also had some lower leg weakness and urinary incontinence. And on exam, you could see that the patient in the eye that had the prior optic neuritis in the right eye was count fingers and had a very pale optic nerve. And now she's presenting with a hyperemic nerve on the left with 2400 vision, so very severe vision loss. When we got the MRI, you can see this profound enhancement of the optic nerve here, where it extends down almost the entire nerve. It doesn't spill into the peribulbar fat, but it is pretty profound enhancement involving that nerve. And then with our T2 flare looking for those white matter lesions, we don't see these periventricular white matter lesions like you see in MS. And, just looking at this picture of this severe vision loss in the right eye, now severe vision loss in the left eye, this profound enhancement, MS wouldn't be very high in our differential diagnosis. And the MRI, again, makes it much less likely as well. So really, NMO is coming to the very top of our differential diagnosis just with the way this patient is presenting to the neuro-ophthalmology clinic. Of course, they also said they had lower leg weakness and urinary incontinence, which of course we'll have to get an MRI of the spine. And as we heard from Dr. Flanagan's wonderful talk, you can see this longitudinally extensive transverse myelitis here and extending over 5 vertebral segments. And this is classic for NMO. If we had the enhancement pattern, we might see that eye of Ceron that he talked about. But I don't have that enhancement here, but this is pretty classic for NMO. You compare that to your classic MS lesion where you've got a much smaller lesion here, so you can see why NMO tends to cause so much more disability in terms of its attacks. And of course, not surprisingly, this patient was positive for aquaporin 4 antibodies. This patient has aquaporin 4 positive NMO. So when you compare and contrast NMO with MS, and again, MS is going to be your typical optic neuritis. With NMO, it has slightly different demographics, where it's about a decade older. It's got even a more higher female predominance than MS. Black and Asians are more affected than Caucasians. And the reason why I care as a neuro-ophthalmologist is the optic neuritis is very severe, with 75% of attacks at nadir having a vision of 2200 or worse. That's legally blind. And unfortunately, the recovery tends to be poor, with up to 50% of patients ending up with a vision of 2200 or worse. You compare that to MS, it's only 3%. So this is magnitudes worse in terms of prognosis. The optic neuritis attacks often are a little bit more posterior, so less than a third have optic disc edema. And again, if they do have disc edema, it tends to be mild. And aquaporin 4 NMO tends to have a predilection of affecting the optic chiasm in about 20% of the time. And sometimes it can be just an isolated optic chiasm attack. And again, you rarely see that in MS. So if you see optic chiasm involvement with an optic neuritis, you want to have NMO pretty high in your differential diagnosis. And of course, the attacks outside the optic nerve are going to make you think about NMO. You've got your longitudinally transverse extensive myelitis and your area postrema syndrome, where you can get intractable hiccups or vomiting. And what's scary about the disease is some of the older literature reported mortality rates as high as 32%. So this can be a fatal disease if left untreated, from respiratory distress and failure. But fortunately, now with better recognition, better treatments, our mortality rates are much closer to 6%, probably even better than that now. But if left untreated, it can be a fatal disease. So because these attacks are so severe, we know the prognosis is so poor, we really have to treat every acute attack very aggressively. And we typically treat with IV corticosteroids and plasma exchange. And most likely, early treatment leads to better outcomes. And there's that saying that time is vision, and it probably really matters for NMO because we know the natural history is so poor. And again, this directly it's completely against what the optic neuritis treatment trial showed us, which is that IV corticosteroids led to faster recovery, but didn't change ultimate outcome. Here, we're completely reversing that. If you've got a patient with NMO and they have optic neuritis, it's as aggressive and quick therapy as possible because we know the outcomes are poor. And again, with the optic neuritis treatment trial, there were no patients that had NMO, and therefore those findings don't apply to NMO. Of course, it's important to diagnose patients with NMO because the long-term treatment is very different as well. As you all know, rituximab is classically the first line. Older alternatives include azathioprine and mycophenolate. And of course, now we have the new FDA-approved medications, eculizumab, inebilizumab, and satralizumab. But again, it's very scary because if you have a patient with optic neuritis and you assume it's MS, but they actually have NMO and you put them on a traditional MS medication, you could potentially increase the relapse rate in NMO. So it's contraindicated there. And that's in a disease that has mortality rate as high as 32%. And so that's why it's so important. We've got a patient with optic neuritis to stop and think, could this be NMO? Because again, not only the prognosis changes, but the treatment changes. So let's talk about MOG, antibody-associated disease. And again, we've had a wonderful collaboration with Sri Lanka, and we know a lot more about this disease, but it is a much newer entity. I thought I would just step through a classic case of MOGAD optic neuritis. This is a 48-year-old male who presented with blurred vision and pain in both eyes. He actually presented about 6 years ago before we actually had the MOG antibody. So at the time, this was a more unusual diagnosis, but he came to the ED, he was count fingers in both eyes with this profound bilateral disc edema with some peripapular hemorrhages. We got an MRI of the orbits, and what you can see is this profound enhancement of the optic nerves that doesn't not only involve the optic nerve, but actually involves the optic nerve sheath and the peribulbar fat. And this is actually a very classic radiologic sign of MOGAD. Just like Dr. Flanagan stepped through these kind of radiologic features of myelitis that might make you think MOGAD versus NMO, this is one that can make you think about MOGAD. So if you look at your diagnosis of optic neuritis, I have a bunch of diseases listed here. And we talked about MS and NMO, but if you had a patient who actually presented with this amount of disc edema with peripapular hemorrhages, this amount of enhancement of the optic nerve with perineural enhancement, I would actually say that MS and aquaporin 4 NMO would actually be much lower in my differential. MOG, antibody-associated disease, MOGAD would go very right to the top. But then you'd also want to think about other diseases like sarcoidosis, Lyme, syphilis, TB, infiltration, and idiopathic. Those would all be on the differential diagnosis as well. but I would not think MS, I would not think aquaporin 4 NMO with this clinical picture. So again, this patient presented 5-6 years ago before we had MOG antibodies. So at the time he was diagnosed with an atypical optic neuritis. It was clearly atypical. It wasn't like MS because it was bilateral, which is very rare in adults. There's that prominent significant disc edema, which we don't typically see with multiple sclerosis and other more typical forms of optic neuritis. The initial workup was negative. The CSF showed no ligoclonal bands. The aquaporin 4 antibodies were negative. The infectious and inflammatory workup was negative. So we just went ahead and empirically treated him with IV methylprednisolone for 5 days. And the patient had almost immediate recovery of vision. Within 2 or 3 days of steroids, the patient went from count fingers back to 20/20 vision. And that's actually much quicker than your normal recovery you get from IV corticosteroids. With MS optic neuritis, the natural history might be recovery at 5 weeks, and with IV steroids, they get recovery at 2 to 3 weeks. But this patient, within a few days, they're back to 20/20. Unfortunately, when we tapered off the steroids, the patient had recurrent bouts of optic neuritis. And every time we treated him with steroids, he got better. But when we tapered him off the steroids, he had relapses. And so clinically at the time, he was diagnosed with chronic relapsing inflammatory optic neuropathy, or CRION. What that means is a steroid responsive but steroid dependent optic neuritis. And the patient was ultimately stabilized in azathioprine 100 milligrams twice a day. And not surprisingly, 1 to 2 years after we initially saw him and we finally had the MOG antibodies, he was positive for the MOG antibodies at 1 to 100, because this is really a pretty classic way that MOGAD can present. So I know this group is very familiar with this disease, MOGAD, but I just thought I'd just provide a little bit of background. MOG stands for myelin oligodendrocyte glycoprotein, and it's a transmembrane protein found on the surface of oligodendrocytes and myelin. And antibodies against MOG are found in a distinct demyelinating disease that we now call MOG antibody-associated disease, or MOGAD. And it's actually only been commercially available in the US since October of 2017. And so, we're still learning a lot about this disease. We've had the aquaporin 4 antibody first discovered in 2004. With this, we've had, access to this for only the past 4 years. But in terms of, we are starting to learn a lot more about it, and it really seems like it can affect any age. We've seen as young as 1, as old as 82, with a median age of 33. It makes up more than, probably a little bit more than 20% of the demyelinating attacks in children, and about 5% of demyelinating attacks in adults. It's got a female to male ratio much closer to 1 to 1 compared to MO, which has a much stronger female predilection, and MS, which also has that female predilection. And for optic neuritis, it's probably about 2 times as common as aquaporin 4 for optic neuritis. In terms of the features of optic neuritis that make you want to think about MOGAD, about up to 50% can be bilateral, up to 50% can be recurrent. Some of them are steroid dependent with that, CRION type phenotype. So these are, if you see bilateral optic neuritis, recurrent optic neuritis, you definitely want to think about MOG antibodies and MOGAD. Disc edema is a potential differentiator. It can be present in up to 86% of attacks. And again, compared to typical optic neuritis, it's only present in a third. And it can be severe with some peripapillary hemorrhages at times, which you almost never see with multiple sclerosis or NMO. So if you see a lot of disc edema with a patient with optic neuritis, MOGAD has to be pretty high in your differential diagnosis. Pain occurs in about 89% of the time, and it can often precede the vision loss and can be quite severe as well. Sometimes it can be described as a severe headache behind that eye, and they still classically have that pain with eye movements. Although MOG optic neuritis tends to present with very severe vision loss at nadir, typically in that 2200 to count fingers range, the recovery, especially with steroid treatment, tends to be much better than NMO. This was a study where we looked at patients with the recurrent bouts of optic neuritis and the chance of retaining usable vision. And in blue, this on the y-axis, this is the chance of retaining good vision. On the x-axis is time from onset. And you can see in blue, this is your aquaporin 4 NMO. And if you've got recurrent bouts of optic neuritis from NMO, the chance of retaining good vision is pretty low. As you can see here, if you've got multiple bouts of optic neuritis, chances are you're going to be legally blind. Whereas in pink, this is your patient with our patients with MOG. Despite recurrent bouts of optic neuritis, patients tend to retain fairly usable vision, and actually looked at very similar to multiple sclerosis in black. Now, overall, most studies show that about 6 to 10% of patients will end up 2200 or worse in MOG, compared to 50% for NMO. So again, magnitudes better outcomes than NMO, fortunately. We talked about these radiologic clues toward MOGAD optic neuritis. With MOG, you often not only have enhancement of the optic nerve, but you have enhancement of the optic nerve sheath. The enhancement can be, again, so severe in about 50% of the time that it spills into the peribulbar fat, which we call perineural enhancement. And oftentimes the enhancement is quite long. It extends down almost the entire portion of the optic nerve. This isn't specific to MOGAD. You know, we'll see this with NMO as well, but we rarely see that with MS. MS tends to cause much shorter segments of enhancement of the optic nerve. So if you see long segments of enhancement, you want to think about MOGAD or NMO. And if you see that perineural enhancement where that enhancement pattern spills into the peribulbar fat, you want to think about MOGAD. So here's our summary of MOGAD optic neuritis. Again, 50% bilateral, 50% recurrent, a good amount have pain. That disc edema is a pretty good differentiator. On MRI, you want to look for that perineural enhancement. And the good part is, again, the vision recovery tends to be good, with only about 6 to 10% ending up with that vision of 2200 or worse. So in terms of treatment, they tend to be quite steroid responsive. And so we typically treat them with IV methylprednisolone for 5 days. And we tend to do a prednisone taper over 1 to 3 months because they're not only steroid responsive, they can sometimes be steroid dependent. I know in the UK, they often do a prednisone taper over 6 months. So, you know, you can really extend that oral prednisone taper if you've got a patient with that steroid dependency with optic neuritis. Because they tend to be steroid responsive, we reserve plasma exchange more for the patients with severe vision loss and no recovery after the IV corticosteroids. Again, that's different from NMO, where oftentimes IV corticosteroids isn't enough. You really need to do a plasma exchange with the IV steroids. With MOG, most patients respond to IV steroids. We kind of keep that plasma exchange in our back pocket in case they don't recover. The other, even probably more large difference is the way we approach these patients chronically. With MS, you know, patients need MS disease modifying agents. With NMO, they need to be on chronic immunotherapy, typically rituximab or one of these newer agents. For MOGAD, if they've got a single attack and pretty good recovery, we actually would not recommend chronic immunotherapy right off the bat, because only 50% of patients are going to relapse. And if they were to relapse, the recovery from the attacks tend to be much better than NMO. So if you treated every single MOG patient with chronic immunotherapy, you'd be over-treating 50% of patients, because again, only 50% are going to relapse. And if they do, you can typically salvage and get good recovery with early steroid treatment. So that's a large difference. Is, you know, we tend to reserve it for only for relapsing disease. And that's when we do our long-term immunotherapy. And then if we do long-term immunotherapy, it's typically one of the medications that we use for MOGAD, for NMO, the traditional ones like rituximab, mycophenolate, azathioprine. And then if they've got relapsing disease, then we may use IVIG. But typically we start off with one of the more traditional medications that were used for NMO just because of the high cost of IVIG. So one of their questions is, you know, how common is MOGAD and NMO optic neuritis, at least in the Western world? A lot of the studies on the incidence of optic neuritis comes from studies at the Mayo Clinic, because we have something called the Rochester Epidemiology Project, where we're actually able to look at the population-based incidence of diseases in Olmsted County. And back in 1985, before we had OCT4, before we had MOG antibodies, it was determined that 52% of optic neuritis were from MS, the rest were idiopathic. Of course, now that we have these new biomarkers, we can actually see, how common are these entities from a population-based analysis. And what we found is that 57% were MS, and now that idiopathic group is going down. Now it's 31%, so about a third. What we found is that 5% were from MOGAD, 3% were from aquaporin 4 positive NMO, 1% was seronegative NMO, and therefore 9% of optic neuritis is going to be either NMOSD or MOGAD. So not the most common in the world, but high enough that if you see enough patients with optic neuritis, you're going to see patients with these diseases. And so you have to have the assign your differential because it ultimately changes prognosis, more importantly, changes treatment. And of course, Dr. Flanagan mentioned this wonderful study in collaboration with Sri Lanka to see, how common are these entities there. And surprisingly, in Sri Lanka, the MOG was actually 17.6%, which is actually on par with how common MS is in that area. And then 5% were NMO. And in the patients with MOGAD at Sri Lanka, almost 2/3 of patients actually present with optic neuritis. So that's going to be the most common presenting feature of MOGAD in Sri Lanka. Final outcomes were very similar to what we saw, where majority of patients had good recovery. So when do we test for these antibodies in the setting of optic neuritis? I think, for any optic neuritis, you could actually do this unless it's classic MS. If you've got a patient with periventricular white matter lesions, oligoclonal bands, mild optic neuritis, that's going to be MS. And just checking for these antibodies, for those patients, you could end up having false positives. So really, if it's classic MS, that's going to be MS. But really, because it changes outcomes and prognosis, it really is required for any atypical optic neuritis. And by atypical, it'll be all those features that we talked about that you see with NMO and with MOGAD. You've got your severe vision loss, the bilateral recurrent optic neuritis, prominent disc edema, long segment enhancement of the optic nerve sheath or chiasm. Or if you have CNS disease outside the optic nerve that's atypical for MS, like ADEM, a long transverse myelitis or area postrema syndrome. These are all things that would make you really want to check for these antibodies. So just want to summarize with this comparison of your typical MS patient, your NMO patient, and MOGAD. With MOGAD, it could be any age, any sex, and then likes to affect children. We really haven't seen a racial predilection for it yet. With MOGAD and NMO, they both present with severe vision loss at onset, but fortunately with MOGAD, you have much better recovery. That optic disc, the optic nerve appearance at acute presentation can really help you swing toward MOGAD versus some of the other ones if you see a lot of disc edema. And of course, that MRI finding of perineural enhancement can make you think about MOGAD, whereas if you see isolated chiasm involvement, you want to think about NMO. Both MOGAD and NMO can cause long transverse myelitis, and you heard from Dr. Flanagan's wonderful talk about how MOGAD can affect the central gray and cause that H sign. And then some of the classic lesions outside the spinal cord or optic nerve, of course, would be MS with your periventricular white matter lesions, NMO, your area postrema, and with MOGAD, you can get ADEM. So hopefully from this talk, you can clearly see that you've got to think about MS, aquaporin, NMO, and MOGAD quite differently. And these biomarkers really have to be tested for any atypical optic neuritis because it not only changes prognosis, but most importantly, really changes treatment. And again, I wanted to thank just some wonderful collaborators at the Mayo Clinic, including Dr. Flanagan, Dr. Pedok, and wonderful collaborators around the world as well in terms of contributing patients and input into these studies to give a better understanding of MOGAD. So I'd love to answer any questions you might have.
Thank you, John, for that excellent lecture. You'll like to answer a few questions. First, can I ask a question? This NMO patients who do bad in their visual functions after the onset, the plasma exchange, how far it can improve the vision?
Yeah, so plasma exchange the earlier the plasma exchange tends to lead to better outcomes. And some patients can have incredibly good recovery. Not every patient's going to end up with poor recovery. So it can recover back to 2020 with normal visual function. Typically, delayed plasma exchange is associated with worse outcomes. Unfortunately, there's no randomized clinical trials doing plasma exchange versus IV corticosteroids versus placebo. So these are all retrospective studies. But really the consistent thing that people have found is that earlier treatment with plasma exchange and IV corticosteroids does tend to lead to better outcomes. If a month out, we'll sometimes still try plasma exchange, but those patients tend not to recover quite as well.
Any other questions? Can I ask another one? This you mentioned that NMO patients do badly after if accidentally given this MS treatment. Is there any particular reason for that?
Yeah, it's not entirely sure why that happens, and it's really kind of the more traditional older ones. Like rituximab, ocrelizumab. Those work for MS. They work for NMO, but some of the older traditional MS medications do not work for NMO, and there's just studies that suggest that there's more recurrent flares with this. I'm not sure why it actually gets worse. It clearly doesn't work, but in terms of why it actually potentially increases the relapse rate, it's still unclear. But clearly the pathophysiology behind the two diseases are just so different, with NMO being an astrocytopathy. These old MS medications clearly do not work.
Okay, thank you again, and we'll show your appreciation. Thank you, John. Yeah.
Great, thank you so much.
Thank you. Now we move on to the final talk in this segment, symposium, on growing spectrum of autoimmune encephalitis, a clinical and a diagnostic update by Divyanshu Dubey, also from Mayo Clinic. Over to you, Divyanshu.
Thank you. Thank you for inviting me to give this talk. I think we'll jump ships, move on from spinal cord to optic nerve, now onto the brain. And I'm going to try to briefly discuss some of the autoimmune encephalitis manifestations in this talk. Much of the research I'll be discussing has been performed at our lab, and some of the people we see in this picture have contributed heavily to it. Lab was initially started by Dr. Lennon, and in the last 30 years, it has grown exponentially. These are my disclosures. I'll be talking about a couple of antibodies we have patents for, plus I'll be talking about some off-label use of immunotherapy for these conditions. So as we go through this talk, I'll try to describe what is autoimmune encephalitis. We'll discuss some epidemiology studies suggesting how common is it. Are the neural autoantibodies which we utilize on a day-to-day basis in our clinic, are they clinically helpful? What are the different methodologies we use to discover these antibodies? And then which patients should we think about sending these antibodies? And when we do send them, and we get a result back, how should we interpret it? A positive result or a negative result? So autoimmune encephalitis diagnostic criteria were put out in 2016 by a group of experts in the field. They utilize clinical characteristics which are predominantly present at the time of patient's initial presentation to formulate these diagnostic criteria, which make these criteria very useful. They divided them into, depending upon the level of certainty, into possible, probable, and definite. For a patient to meet possible criteria, he or she had to have subacute onset of working memory deficits, altered mental status, or psychiatric symptoms with at least one of the following: new focal CNS findings, seizures, inflammation in the CSF, or MRI suggestive of encephalitis. So it was still a relatively easily met criteria, but that's why it was considered possible. And for any patient to be possible, you had to exclude alternative etiologies. If anybody had possible criteria and then had a neural specific antibody with high specificity for an encephalitis phenotype, they automatically became definite autoimmune encephalitis. Probable autoimmune encephalitis, which were the seronegative cases with a slightly higher level of certainty, needed to have additional, more stringent criteria met. So at least two of the following: MRI abnormalities, CSF phagocytosis with oligoclonal bands, or evidence of inflammation or encephalitis on brain biopsy. So slightly more stringent criteria. But these criteria come in extremely helpful, not only in management of patients, but also in performance of population-based studies. So we utilized our Rochester epidemiology cohort, which was briefly touched on by Dr. Chen, for estimation of incidence and prevalence of these conditions. And to our surprise, we found that autoimmune encephalitis, when compared to infectious encephalitis, at least in Minnesota, was not very different. If anything, it was slightly higher. The picture might be different in Sri Lanka or in other parts of Indian subcontinent, but here it seemed it was about the same. And then interestingly, as you can see in this figure, the incidence of autoimmune encephalitis seems to be increasing over time, nearly tripling from 1995 to 2005 to 2005 to 2015. And most of it is coming from antibody positive cases, because it's probably not because the rate of autoimmune encephalitis is going up. It is probably because the recognition of encephalitis is going up because of more utilization of these antibody panels. And if we extrapolate our data on a worldwide scale, we can say there are about 1 million cases of autoimmune encephalitis worldwide, and about 90,000 people get autoimmune encephalitis every year. So it's not as uncommon as once it was thought to be. Moving on, we'll talk about some of these antibodies which have played a crucial role in our improving our understanding as well as recognition of these conditions. Up till mid-1990s, the number of antibodies were limited. The ones in green are the ones which are, against antigens inside the cell, whereas the ones below are against antigens which are present on the plasma membrane or on the surface. And since mid-90s, the number of autoantigens to which these antibodies are targeted towards have exponentially increased. And this has, to some extent, contributed to increased recognition, increased understanding, and more sort of optimal management of these conditions. So I'll divide these conditions now into the cell surface as well, or the intracellular. We'll talk about the antibodies targeting cell surface antigens first. In most of these scenarios, the initial input or initial trigger is either a tumor or a virus, or in many cases, we just can't figure out what triggered this autoimmunity. And when this happens, it leads to presentation of antigen to the immune cells, the T cells, B cells, or the T helper cells in the regional lymph nodes where the tumor is happening. And this leads to development of an immune response. When talking about antigens which are present on the cell surface, the more predominant or important response for us to understand is the B cell response, which leads to formation of these antibodies, and these antibodies go act on the antigens themselves, sometimes causing internalization, other times causing disruption of their function or activation of complement system. Understanding what the antibody's function is, or if the antibody is pathogenic or not, can provide us not only helpful information to diagnose the patients, it can also provide us some additional information in terms of how to treat the patient. So some of these antibody-mediated conditions that we were just talking about with MOG or aquaporin 4, utilization of plasma exchange, IVIG comes in to be handy. Utilization of B-cell therapy, CD20, CD19 therapy, or IL-6 therapy recently for aquaporin 4 comes in to be handy. And then it also tells us, to some extent, it gives us an idea what is the chances of the patient having an underlying cancer. So I'll go over some of the important antibodies in this group very briefly. LGI1 is one of the antibodies which Dr. Irani will be talking after me, will highlight and will talk about. It's an antibody which we see more and more both in inpatient as well as outpatient clinic. In my experience, majority of these patients are men, older individuals, usually more than 50 years of age. I've had patients even in their mid-90s have this particular syndrome. Majority of these patients present with seizures at the time of presentation. One pathognomic feature or pathognomic seizure semiology, which we are aware of, is the facial dystonic seizures, where the patient presents with dystonic movements of the face and arm. But there are other seizure presentations as well. These tonic or dystonic movements not only affect the face and arm, we've had cases where these dystonic movements just affect the leg. So just a month ago, I had a patient who came in presenting with frequent falls because these dystonic movements were just limited to one leg. The other seizure semiologies include pilomotor seizures of goosebumps involving one half of the body. We've had cases of sensory seizures, many a times which are called psychogenic. And then we've had cases of ictal bradycardia where the seizures are causing bradycardia to an extent that one of them required a pacemaker. In the past, at least some researchers initially thought this was sort of a one and done kind of a syndrome where it happened and then went away. But as we learn more and more about this condition, we realize that the utilization of chronic immunotherapy may be important. Many of these patients tend to have relapses. In our experience, the relapses tend to be slightly more early on in the disease course. And some of these patients tend to go on to develop chronic epilepsy. So it's a minority of cases, but there are a few cases where even when the encephalitis phase resolves, they can continue to have seizures. In our recent study, the risk factors for chronic epilepsy included female age or early age of onset of many of syndrome in many of these cases. Another antibody, which is initially described in association with voltage-gated potassium channel antibody, is Caspr2. We know about the peripheral manifestations of Caspr2, but it can also cause encephalitis and seizures associated with encephalitis. These are some images from our recent study where we categorized seizure presentations and semiologies in patients who presented with Caspr2 autoantibodies. These were all men. Most of them had features of autoimmune encephalitis, some of the features which we talked about at the beginning of this talk, but there were others without features of encephalitis, just isolated seizures as their presentation. The other red flags that should make us think of Caspr2 immunity, or at least the CNS manifestation, are presence of episodic emotional lability. A few of these patients told me that they were all of a sudden, they just couldn't control themselves and had these episodes of brief laughter or brief crying without any inciting event. Another presentation which has been described previously with Caspr2 is episodic ataxia, where they have these episodes when they have significant truncal ataxia or even speech dysarthria. And then another presentation which was unique or was interesting to find in these cases was these brief episodes of dizziness, which lasted for a few seconds, happened multiple times a day. We think some of these could have been sort of auras or small seizures happening in these patients. This MRI shows some patients with limbic encephalitis like MRI changes, but again, it's not found in all cases. So completely normal MRIs should not dissuade us from Caspr2 testing. If the patients have some of these features, then we should probably consider Caspr2 IgG evaluation. One thing to keep in mind is the way most of the labs are testing Caspr2 IgG is by cell-based assays, especially a Neuroimmune-based cell-based assay. And sometimes titrations are not performed. Low titer Caspr2s in our experience can be false positive, and we've seen them in a variety of conditions which do not necessarily have a clear association with the described Caspr2 neurological autoimmunity. Moving on, this is, since we were talking about peripheral manifestations, this is one of my patients who presented with diffuse muscle twitches all throughout the body. A 19-year-old gentleman who also had cramps and had CNS manifestations in terms of neuropsychiatric response. And then when we stuck a needle into his muscle, we could hear this asynchronous marching of the soldiers, consistent with like myokine. So this is a presentation which is suggestive of ISAC syndrome, and subsequently when he was tested, he came back positive for Caspr-2. So the Caspr-2 autoantibody can be seen in peripheral hyperexcitability syndrome as well. Moving on, an important antibody which was pretty significant for our field was an MDA receptor IgG. Most of these patients present at a young age. Many of them have neuropsychiatric presentations at the onset, can go on to develop encephalopathy, seizures, certain movement disorders. This is one of the patients I saw some time back who initially came into the ED with neuropsychiatric manifestations and then continued to worsen. What we are seeing in this video is the chewing movement around the tube, which is consistent with oral dyskinesia, which which can be seen in many of these patients. Other presentations which we've noted with an MDA receptor encephalitis is catatonia. We've had cases of chorea as well, which can sometimes be associated with this presentation. MRIs are usually unremarkable, but lately studies have suggested that FDG PET can be utilized, shows occiput low hydrometabolic. In addition to the paraneoplastic association that we are aware of with ovarian teratoma, recent studies have highlighted a post-infectious neurological autoimmunity in patients with HSV encephalitis who come in a couple of weeks later and actually we end up finding out that they have NMDA receptor antibodies. Just something to think about if a patient is having HSV encephalitis and coming back within 2 to 3 weeks or 4 weeks, so we should always consider NMDA receptor IgG. Another cell surface antibody present in can be detected in older individuals presenting with acute onset encephalopathy or non-convulsive status is GABA. And other phenotypes include rapidly progressive dementia. About 50% of cases have underlying lung cancer or small cell lung cancer. And there's a recent coexisting antibody which was described by Dr. Titulaer's group, that's KCTD16, which present along with GABA-B increases the risk of small cell cancer to up to 95%. Moving on from cell surface antibodies to intracellular autoantigens. Many of these autoantigens have a strong cancer association. So recently, many of us who work in this area came together to come up with an updated version of paraneoplastic criteria, where many of these antibodies or intracellular targeting autoantibodies were classified as high risk or moderate risk biomarkers for underlying cancer. So highlighting that utility of antibodies is not just limited to syndrome identification. In many of the cases, this can direct cancer surgery. So again, going back to our figure, which we had initially seen, an inciting event could be a tumor. In these cases, more likely a tumor. Antigen presentation. In these cases, what we are more interested in is the cytotoxic T cell response. We think the antigen not only leads to B cell activation with the help of T helper cells, leads to development of plasma cells and increased antibody production, which work as red flags or biomarkers of disease, but it's the disease itself is actually being caused by cytotoxic T cells, which we think many of these cases are attacking the same protein. Some of this initial data came from work done in late 1990s on anti-Yo antibodies. The recognition of these antigens not only helps us with diagnosis, with therapeutic implications, because most of these therapies are then sort of focused on cellular immunosuppression, so utilization of cyclophosphamide and rituximab, and then it can also, as we were talking, it can direct our cancer. I'm going to go over some of these intracellular biomarkers now. Many of them are more novel or newer biomarkers. Among these, one of the antibodies of importance is Kelch-like protein 11, or what we call as Kelch-11. This was discovered in a collaborative effort between Mayo Clinic and UCSF. This particular green image you're seeing at the top is a section of mouse brain showing the periventricular region. And these dotted areas seeing, we refer to the sparkles because of this sort of dotted stars in the night sky kind of staining pattern. So we have been seeing these sparkles pattern for quite some time, about 10 to 15 years. And then working with UCSF, we utilized technology called as phage immunoprecipitation sequencing to detect underlying protein to which is leading to appearance of these sparkles on tissue immunofluorescence assays. This is a very interesting technique which is being utilized more and more now for biomarker discovery, where we include all known human proteins using UniProt database, take small peptides of these proteins, and then insert them into bacteriophages. So then you can imagine we have a test tube of bacteriophages, millions and millions of bacteriophages with small peptides on their heads, which can be utilized for immunoprecipitation and subsequently could be sequenced to identify the antibodies each individual has. So utilizing this technique, we found Kelch-11, and then lo and behold, in our experience, it seems to be one of the more common biomarkers of ataxia in men. Majority of the cases I see here at Mayo Clinic are young men. Most of them have underlying testicular cancer. Some of the testicular cancers are actually not in the scrotum. They're in the mediastinum or retroperitoneum, highlighting the importance of utilization of PET scans in many of these cases. The clinical phenotype most commonly is rhombin encephalitis, brainstem predominant presentations, or rapidly progressive cerebral ataxia with coexisting brainstem involvement. And some of the cases can also have limbic encephalitis or both limbic encephalitis and brainstem. One important thing which I would like to highlight, many of these cases have hearing loss along with these CNS manifestations or preceding these CNS manifestations. So that's one red flag we should keep in mind. Young patient presenting with asymmetric onset hearing loss, progresses, goes on to affect the other ear. Soon the patient starts developing double vision or speech changes. That's a major red flag or a classic story of Kelch-11. These are some of the patients I've seen here. This particular gentleman came in with a very classic story, had loss, had to have hearing aid replacement, that didn't work, had to undergo cochlear implants, that didn't work, and then he continued to progress over time. As I play the video, if you can hear his speech, see how disarthric he is, and he's describing his story.
Oh wow, 5 months ago, I was starting to working.
So what he's saying is 5 months ago, he was working, and within 5 months, he's had such a significant progression. This is another patient of mine who came in presenting of oscillopsia. His complaint was whenever he sat down to watch television at night, the whole TV was moving. And as we watch this video of infrared recording, he describes when the oscillopsia starts and when it stops, and you can see the nystagmus start and stop at the same time.
This will happen.
It'll just kind of keep coming and going indefinitely.
Yep. Mm-hmm.
But it does kind of start and stop.
Yep.
Start and stop.
Definitely.
You tell me when it stops.
It usually stops and then it starts right away. Stops. Started.
As you can see, whenever the nystagmus starts, you can start seeing that oscillopsia of illusion of stationary things moving around. These MRIs again highlight the brainstem predominant presentation in many of these cases. We looked into this clinical presentation and progression, and the study again highlighted the importance of recognition of the cochleovestibular involvement in these cases. Many of these patients presenting with hearing loss, which is shown in the gray dot, months before they had the CNS manifestations. Others had very classic peripheral vestibulopathy, which was diagnosed as BPPV, which preceded CNS manifestations by many months. To understand how this disease is caused, given the intracellular nature of the antigen, we utilize the PBMCs from these cells, these patients, or lymphocytes from these patients, and then co-cultured them with antigen presenting cell in the presence of the recombinant Calc11 protein. And what we saw was there's clear activation of the patient's lymphocytes, specifically CD8 lymphocytes, in the presence of the protein, suggesting an autoantigen T cell driven disease. We did additional sort of subcategorization of these antigens using CyTOF techniques. And what we found was these cells which were activated were cytotoxic effector memory T cells, which sort of hang around even after the underlying tumor is removed in many of these patients, highlighting the importance of chronic immunosuppressive therapy in many of these patients. So just taking out the seminoma, which usually is never a problem in terms of cancer, is not the answer. These patients require first-line therapy, seminoma treatment, and then chronic immunosuppression. Most often the agent I utilize is either IV or oral cyclophosphamide. Moving on, another technique which has been sort of the workhorse for most of our discoveries in the lab, which led to some important discoveries such as CRIMP5 or aquaporin 4, is this IP mass spec technique. I've tried to simply explain it in 3 steps, but these 3 steps can take up to 10 years to perform. Step 1 is to find a rich antigen. It could be a part of the brain where we think the antigen is present based on the tissue IFA images, some of those green images I was showing you. It could be a cancer based on what is the underlying cancer association with the paraneoplastic syndrome. Step 2 is to run this on a gel and to find a common band, purify that those antibodies binding to the common band, and then utilizing that purified antibody to do an immunoprecipitation assay, which goes to mass spec, and hopefully the number, when you get the hits, which are usually always too many, the top hit or the most relevant hit is hovering in the top 10, 15 counts. And then using multiple different patients, we sometimes are able to figure out what the relevant hit is. This is the technique we utilize to discover this antibody called as leucine zipper 4, which is another biomarker of germ cell tumor associated paraneoplastic syndrome. We again demonstrated that it's not the antibody, but the T cells we should be concerned about in this disease. Many of these patients have both Calc and leucine zipper 4 positivity, but an important thing to notice here is many of these patients have involvement of the anterior horn cell. As you can see from this picture, they can look like biallelic ALS presentations or motor neuron disease presentations. This is one of my patients who had just significant weakness of both limbs, who was positive for this antibody.
In your hands and lift your arms a little bit.
As you can see from the video, he doesn't have anti-gravity movement.
Right. How about making fists? Fists. Okay. And then open the hands again. Right. In your hand.
Moving on, another group of challenging cases we are seeing more and more in our inpatient as well as outpatient practice is our complications of immune checkpoint inhibitors. These are a few cases we saw, some of them we saw in our clinic, others we came across in our neuroimmunology lab, and the patients were seen elsewhere. This particular first patient had got pembrolizumab, cancer immunotherapy, and subsequently developed limbic encephalitis, as you can see from the MRI. His sample was sent to our lab for testing for autoantibodies, which can help predict the natural history or potentially direct treatment. These other two patients also developed CNS involvement in form of brainstem involvement or cerebellar ataxia following immune checkpoint inhibitors. The common thing in all of these three cases was the tissue immunofluorescence pattern. So again, going back to those thin sections of mouse brain, when the patient's serum or CSF was added, we saw this very unique pattern, which if you sort of can allow your imagination to run a bit wild, kind of looks like tadpoles, or at least that's what I called it when I was seeing these patients in the lab. So we started to see more and more of these patients for some reason in the last few years, and we collected them all, and we came up to a number of 22 cases. Most of these had either cerebellar syndrome or had a classic limbic encephalitis presentation, and more than 80% of the cases had underlying cancer. Most commonly neuroendocrine tumors such as small cell lung cancer or Merkel cell tumors, etc. To detect what was the underlying protein which was given this tadpole appearance because of binding of the patient's antibodies, we utilized a third technique, which is called as a human proteome microarray. This microarray is more than 20,000 full-length, includes more than 20,000 full-length proteins, which when the patient's serum or CSF is screened with, we can detect binding of patient's antibodies to different proteins. And if you have a group or a cohort of common appearing immunofluorescence patterns, you can identify the protein hits which are consistent in that particular cohort. And in this particular cohort of samples, what we found was the antigen which was of relevance was TRIM46. We subsequently got COS7 cells, transiently transfected them with a plasmid, had led to overexpression of TRIM46, which you can see in the green signal here. We utilized patient serum and CSF with a TRITC secondary and showed as red signal here, showing classic perfect co-localization, confirming that TRIM46 was the hit we were looking for. And then subsequently, one of our fellows started doing literature search as a part of, as we were starting to put our manuscript together. And that's when we found out that this particular staining pattern was previously described in 2009 by a group, and then subsequently by a different group, led by a different group of authors using the same patient serum. TRIM46 had already been described. So that sometimes happens to us. When we get excited, discover a pattern, and we end up figuring out that it's already described. But we ended up publishing the study, adding additional 25 cases to the literature, highlighting that this particular antibody should also be considered as a classic high-risk paraneoplastic antibody. So as we started this conversation about TRIM46 immune checkpoint inhibitor use, we've recognized that with increasing utilization of these cancer immunotherapies in various oncology centers, we are starting to see more and more cases of encephalitis. Many of these encephalitis cases don't have a classic paraneoplastic presentation, but some of them do. Especially the patients who have small cell lung cancer and are getting these checkpoint inhibitor therapies, we are starting to see more classic paraneoplastic phenotype resembling presentations. And many of these encephalitis patients have underlying neurospecific antibodies ranging from GFAP, amphiphysin, anti-Hu, or ANA1, etc. Recently, a bunch of us who deal with these cases came together to suggest a consensus disease definition where we subcategorize these manifestations into 6 different phenotypes and provided some recommendations in terms of how to manage these cases, what all workup is needed, etc. So not all of these cases require aggressive management. Sometimes some of these patients just require steroids and that leads to improvement. But there are other cases, especially the ones which resemble the paraneoplastic neurological syndrome phenotype. Most of those patients require more aggressive treatment, including utilization of steroids during agents. Moving on to antibodies which are against antigens inside the cell, but don't have such as strong of a cancer association. GFAP is one of the more common autoantibodies. It was mentioned in Dr. Flanagan's talk as well. Most of these patients present with encephalitis. Many of them can have this MRI, which looks like rays of sun extending from the ventricles, but not all of the patients do. So absence of this MRI in a patient with encephalitis or meningoencephalitis and GFAP positivity doesn't necessarily make the patient false positive. Many of these patients, at least based on the experience we have had here in the US, are presenting to the ER and are being diagnosed as aseptic meningitis because of the significant meningeal involvement and lack of detection of a bug. But testing for GFAP can potentially lead to answer in many cases. Some of these patients can have coexisting NMDA receptor antibodies or upper cortical antibodies. The important thing, what makes it important to that we should recognize these cases is how steroid responsive they are. Some of these cases do relapse, so I tend to utilize mycophenolate or CellCept in many of these patients to prevent relapses. And then the cancer association is much lower than the other antibodies we were just discussing. It's about 15 to 20%, especially in young women. We should look for ovarian teratoma. Another antibody which has been around for quite a while, we know it in it has been described more comprehensively in association with cerebellar ataxias and stiff person syndrome, but it can also present with limbic encephalitis. Many of these patients can have more indolent course without significant encephalitis features, just presenting as epilepsy. And we recently described a cohort of cases with musicogenic reflex epilepsy who had GAD65 positivity. So this seems to be a unique seizure physiology which can be seen in presence of GAD65. So this patient, this is a patient EMU video. You can see in response to music, he's having a right temporal lobe seizure with oral automatisms, lack of response to commands on the right side, but he's able to follow commands. Lack of response to commands on the left side, but able to follow commands on the right. In our EMU, we had 16 such cases, and 9 of those had antibody panels sent, and all of them had presence of GAD65 antibodies, which is very interesting. So moving on sort of towards the end of the talk, briefly touching on when to send this panel. I think one of the important things is to utilize that 2016 diagnostic criteria to identify patients who are likely to fit that possible criteria. An alternative is utilizing scoring systems. One of the scoring systems I had come up with some time back is this APE2 score, which incorporates a lot of those clinical and paraclinical variables which we talked about, including new onset seizures, neuropsychiatric manifestations, autonomic dysfunction, presence of viral prodrome, or certain involuntary movements, such as facial dyskinesias, or presence of inflammatory changes in the CSF or MRI of the brain. This particular scoring system can help utilize, help to identify antibody panel. So this is a quick case of sort of how to utilize the panel. So the scoring system, a 60-year-old male who presented with new onset seizures, refractory to seizure medications, had some behavioral neuropsychiatric changes, and had high CSF protein. If you apply this score, he gets a 1 for new onset seizures, 1 for neuropsychiatric changes, 2 for refractoriness to severe medications, 2 for inflammatory CSF, with a total of score of 6. Anything above 4, I would suggest sending a panel, because that's what sort of was found in the study. And this patient who came back positive for GABA-B receptor IgG and was subsequently treated, and as a part of the workup, was found to have small cell lung cancer, which is detected in 50% of GABA-B. Lastly, when we do send these panels and we get the results back, they're either positive or negative. So one of the things which I'm regularly faced with is how to interpret these results. One scenario where you think it's an autoimmune neurological disorder, but the panel comes back negative. What to do in that scenario? One possibility is the patient might have an unclassified antibody, as was the case with Sparkles up to 2 years ago. So touching base with the clinical lab, which is doing the test, might be helpful. Secondly, what specimen was sent? If the CSF was sent for a LGI1 or Casper2 case, especially in our lab, we've seen that the sensitivity of CSF is somewhat lower than serum. Similarly, if serum was sent for NMD or GFAP, then those could be falsely negative. What assay was utilized? Certain line blots can generate false negative results. And then when was the antibody testing done? If it was done after plasma exchange, then the chances of finding the antibody might be higher in the plasma exchange back. Moving on, the more relevant question, or more important question is, if the panel comes back positive and the phenotype doesn't fit. This is something which we are faced with more commonly in our clinic for some of the referrals. Then what sample was sent is very important, because serum, NMDA, and GFAP can generate false positive results. The assay utilized, some of these dot blots can generate false positive results, especially for the paraneoplastic antibodies. Is the antibody any good? We have recognized that striational antibody does not have any specificity for neurological phenotype. Hence, that it has been excluded from most of our panels. And then the titer of the antibody, which might be relevant for antibodies such as GAD65, which in low titers can be present in normal individuals as well. So the take-home points of this talk are: 1, autoimmune encephalitis is not as rare as it was once thought to be. The utilization of antibodies can not only help us with diagnosis, but also provide insight about the natural history of the disease, cancer association, and selection of treatments. New antibodies are being discovered nearly every few months, which might end up making to some of these panels which are being offered. And then when clinically indicated, I recommend sending both serum and CSF for autoantibody testing. A negative result does not rule out diagnosis of autoimmunity. And in most of the cases where I have a strong clinical suspicion, I recommend starting immunotherapy even before the antibody results are available. Thank you.
Thank you very much, Divyanshu, for that excellent presentation on the spectrum of autoimmune encephalitis. Unfortunately, in the interest of time, we would not be able to take any questions. So that brings to the end this symposium in collaboration with the Mayo Clinic. I would like to thank Eoin, John, and Divyanshu, the 3 panelists, and thank you for that excellent symposium. Thanks a lot. Now we move on to the final talk for the year, this Congress. And I would like to call upon Professor Chang and Dr. Divakaran to chair the...
Good afternoon. It is my great pleasure to introduce Prof Sarosh Irani, good friend of mine. He is associate professor and honorary consultant in Oxford. Sarosh is the head of the Oxford Autoimmune Neurology Group. He's made some very significant contributions to the field of neuroimmunology, There are many, but I would just like to highlight some of the very, very striking ones that he's made. One of them is the recognition of the facial-brachial dystonic seizures in LGI1 encephalitis. And the other, which I thought was very significant, was the discovery of LGI1 and Caspar-2 antibodies in limbic encephalitis. So I think it would be right to say that Sarosh is one of the authorities in the field of autoimmune encephalitis, and it's absolute privilege to have him here today to talk to us on his topic today. So over to you, Sarosh.
Thank you, Tashi. Very nice to see you, even though we're far apart, but hopefully that won't last very much longer. And thank you to the organizers as well for the invitation. So as Tashi said, we know each other from Oxford, and I'm going to tell him about some of our discoveries in Oxford over the last few years. Some since you've left, Tashi, and talk to you a little bit about how these sets of discoveries really allow us to clinically distinguish patients with autoantibody mediated encephalitis syndromes. So our work really starts with patients. We always start on the left of this diagram: phenotypes, presentations, responses to therapy. And then we've got very interested in the last few years about trying to link up this whole pipeline of taking work to the cellular immunology, which I believe is likely to be the etiological and therapeutically relevant basis for treatment in these patients, through to isolation and work on polyclonal antibodies from serum and CSFs. More recently, we've been able to isolate many monoclonal antibodies and study their characteristics, and then take this into the neuroscience, both in vitro and behavioral neuroscience, and really keep asking about treatments, keep asking about how we can develop the science so that we can understand the treatments and feed back to our clinic. So today I'm going to talk to you a little bit about the principles of accurate antibody detection, particularly building on something you've heard from Dr. Dubey a few minutes ago, and then talk about the three commonest forms of antibody-mediated encephalitis associated with LGI1, NMDA receptor, and Caspar-2 antibodies in that order in our experience, and then illustrate each with examples of genetics, immunology, and neuroscience, which I think informs our understanding of the illness very broadly, but also impacts our clinical care. So the first aspect I'm going to go back to is the concept of where the antigen lies. So in disorders where, for example, the antigen is intracellular, you can see a blue star here depicting Hu, the Hu-D antigen. The antibodies against that protein can't access the cell. They can't access their target. And so we think they are important biomarkers and bystanders of the immune activation, but we think this is a T-cell mediated disease. By contrast, there's been a large surge in the number of disorders that we now know are associated with antibodies that directly target the extracellular domain of key surface neuronal proteins. These include the NMDA receptor, and I'll show you many more examples as we go along. But here are just some of those examples. And by differentiating between these, what I'm calling extracellular or surface antigens versus intracellular targets, you really define patients who have a clear treatment response. And that's what I think is the main point of these disorders. You also tend to define patients who have a lower tumor association. And just to build on that a little bit more, the characteristics of these antibodies which target extracellular epitopes are that the patients tend to respond to immunotherapy over conventional agents, and I'll show you a couple of examples, that the phenotypes are highly clinically characteristic, and I would say many are pathognomonic. And the in vitro and the in vivo data are relatively easy to generate because once you incubate the antibody in the in vitro or in vivo system, it has direct access to its target. And that's why we go to the effort of running live cell-based assays, as you heard earlier today from Dr. Flanagan with aquaporin 4 and MOG, IgG. We run these for all the antigens we test. So we are able to say that for sure the patient's antibodies are binding to the live cell expressing the target, and hence must be binding the extracellular domain of that target. And this is one of the very beautiful pictures we can get when we perform those assays. When you don't know the assay target, instead, you can culture neurons in vitro. And when you're agnostic to the precise nature of the antigen, you can just ask, do the antibodies bind anything on a live neuron? And you can see here the green binding demonstrates IgG deposition. And so we know this patient has a surface antigen. And in complement to that, you've already seen examples of how we can stain brain sections and look to show that they bind the patient's antibodies as well. And you've seen a similar timeline before, but just to emphasize this surge of green on the right and blue more on the left. I haven't included everything, but there's been a marked flurry in the number of surface protein targets that have been detected over the last few years. So I'm going to start with what in our hands is the commonest of these disorders, both from our serological testing findings and from our everyday clinical practice. So patients with LGI1 antibodies present typically in their later years and have a subacute onset presentation. This is what I mean by later years. In fact, I think there are only 2 children in the literature with this disease. The median age of onset is 65, and there's a male to female bias here as well. So very unusual for autoimmunity. And they present with seizures, amnesia, disorientation, sleep disturbances and pain amongst a number of other symptoms, but these are probably the core symptoms, with seizures and memory problems being the main 2. And when you look at the sort of criteria available for autoimmune encephalitis, actually these patients fail to fulfill many of these criteria. And as this is the commonest form of autoimmune encephalopathy or autoimmune encephalitis, I think these criteria must be taken with a little bit of a pinch of salt, because, for example, here they talk about a subacute onset of less than 3 months, but actually many of these patients will present to nadir over several months, 6 to 8, 12 months sometimes. The criteria also talk about focal CNS findings, which is rare in this condition, seizures, which is, I would say, universal in this condition, and a CSF pleocytosis, which again is rare in this condition. The MRI, when we see it and it's classical with this beautiful hippocampal amygdala high signal, it's very easy. But the more we recognize this disorder, the earlier we see these patients. And I think that the rates of MRI abnormalities now are below 50%. So they don't fulfill these criteria, even for possible autoimmune encephalitis. They're an unusual syndrome. And one early clue often is this low serum sodium, seen in about 40% of the cases. But I think the real hallmark of this disorder is seizures. And I think the seizures are highly characteristic and have a number of unusual features. First of all, semiology. You've heard about facial-brachial dystonic seizures. I would say these are pathognomonic. I've never seen a video where I've been convinced that's the right clinical disorder without the presence of LGI1 antibodies. Another unusual, but again, characteristic feature are these paroxysmal dizzy spells, which are very brief episodes, which have a number of associated ictal features, but they're just very brief episodes of intense dizziness. So very unusual seizure semiology. Similarly, piloerection is seen in many of these patients, and in surveys of video telemetry cases, it's clear that piloerection is pretty rare, but when present, may well be accounted for by autoantibodies in a large number of the patients. You heard about these thermal and sensory sensations the patients describe, and about their bradycardia tachycardia. And I think, again, whilst not specific, these are quite useful signs in delineating this entity. And then, of course, they get a number of more traditional medial temporal lobe semiologies as well. The other really interesting feature about these patients is traditionally they have more than one of these in any individual. So multiple semiologies presenting acutely and presenting with a very high frequency. I often say that if you don't see one of these in a ward round, it's probably not the right diagnosis. And I think that is probably correct. These patients have very frequent attacks, certainly more than one per hour. But when they get to their worst, they're having 80, 90 seizures easily a day. And I'll show you a couple of examples. This lady, interestingly, presents with prominent cognitive impairment as part of her semiology, her right side, her right face, and her right hand. And this video is not on a loop. This video is edited a little, but you'll see that she has another essentially identical episode. So very stereotyped disorder. And again, you'll see this was adult onset. This affects the arm and the face. You'll agree that it was frequent, it was brief, and there was this posturing element to it. So it wasn't myoclonic, it wasn't as quick as myoclonus. I would call them more dystonic, and they're very stereotyped episodes. And the other thing is that they can present in patients who don't have cognitive impairment. So the seizures can come alone. And this gentleman's a very good example of that. If you watch the side nearest the camera. So there was his first attack, and he continues to type through it. And I'm reassured by his wife and his colleagues that as he continued to work through this period, his emails made sense. He was cognitively normal, and you saw another small episode there. So again, highlighting the really intense frequency of these attacks. And what we began to see was these patients were not uncommon. So roughly a quarter of patients would never develop cognitive impairment. So the ones who did have cognitive impairment had all the test results you might expect. So these are the MRIs of temporal lobes, basal ganglia, EEG findings, this low serum sodium, and CSF abnormalities. And if you look at the tally of these, or the sum of these on the right-hand column, you'll see that pretty much every patient had at least one of these, if not many. So the tests were helpful in this group of patients. But in the quarter or so of patients who didn't have cognitive impairment, the tests were pretty unhelpful, often either non-specific or completely normal in a large number of patients. So what I'm really trying to get across here is this is a clinical diagnosis. And it's really important to spot these patients for a number of reasons. The first reason is their treatment. And this is a very striking but very straightforward plot of patients with ongoing seizures, ongoing fatiobrachial dystonic seizures in this case, and their response to anti-epileptic drugs in red here. And you'll see that really only about 10% of them make a response to anti-seizure medications. And it's later that you get this clear drop-off. But the reason you get a very clear drop-off is because the number of patients is really low in the analysis now. And the reason the number of patients is so low in the analysis is because they've all responded to immunotherapy. So the addition of immunotherapy, steroids, IVIG, or plasma exchange in this context at, say, 2 months here, gives you an 80% seizure freedom pretty much. So we're talking about a really, really immunotherapy responsive set of seizures. And when you compare the patients, when you take this blue line and you divide it into those with and without cognitive impairment, you'll see that those without cognitive impairment in the pink line here did even better. So these patients have an even more exquisite immunotherapy responsive syndrome. But there's another really important reason why recognizing this clinically is of great value. And it really relates to a very simple message you can get by speaking to the patients and their relatives in clinic. And it's really important to speak to their relatives as well, because what they tell you is that the seizures came first in most cases. It's certainly not all cases, but I would say 70 to 80% of cases, the history is of seizures first. And of course, we've already said the seizures are characteristic, so they're recognizable, but they're also immunotherapy responsive. And so we asked whether if you treat the seizures at the time when they have appeared first before cognitive impairment, sometimes a lag of several hundred to even a few years, several hundred days to even a few years, you see, we wanted to ask whether this can prevent the onset of cognitive impairment. And that's exactly what we saw. And it's one of those analyses where you don't really need a statistician around, because when your seizures stop, you essentially don't develop cognitive impairment. But if your seizures continue, you accrue cognitive impairment. So it leads us to propose a model for this disease where function can be relatively quickly restored and relatively completely restored if you have seizures only, but with later immunotherapy, the onset of cognitive impairment, you're essentially left with a fixed deficit. And it's very hard to think of a way to explore this fixed deficit in patients themselves in terms of its etiology. So we have turned to animals for this kind of experiment. And what we've done is we've made monoclonal antibodies from the patients, and we've injected them into the hippocampus of mice. So these stereotactic injections allow us to then, a few days down the line, make recordings from the hippocampus to understand the electrophysiology, and then also to understand the behavior of these animals. And this has highlighted a number of abnormalities. So for example, the animals fail to recognize objects. This is a novel object recognition index. This is what they should do, and this is what they do with injection of the LGI1 antibody. And also in terms of a classic paradigm of memory and learning, so long-term potentiation, you should normally be able to induce long-term potentiation with this arrow, a train of electrical stimuli, and you should maintain it here. So this is the concept of learning at an electrophysiological level. But when you pre-injected the antibodies to LGI1 in blue or red, you fail to do that completely. You abrogate that learning. So the antibodies clearly mimic many aspects of the human disease, and now we want to study how they might induce that fixed deficit we see in the patients. And this kind of data leading to understanding what the mechanism of these diseases is, in this case, an antibody-mediated mechanism, has led to the first randomized controlled trial of these patients with LGI1 antibodies using a drug called rozimab, or rosanolixizumab, which is a blocker of, it essentially accelerates the metabolism of IgG. And so this drug here would directly act on antibody-mediated diseases. And if effective, it would certainly help conclude that this disease is classically antibody-mediated. So the cousin disease really, once upon a time thought to be part of the same syndrome, is associated with antibodies against caspase-2. And you've heard bits about this, but I'll just highlight a few bits just with one slide to show that this disease is a male-dominant disease. And interestingly, we see that this disease can present very insidiously, sometimes over 2 to 3 years. And I'm sure this condition remains under-recognized because of this very gradual onset. Patients, especially those with the Morvan syndrome, can have thymomas. And these patients have an array of features. Some features we can't quite explain, I think it's fair to say, like the weight loss. Others, perhaps we can by the distribution of the antigen, but sleep disorders, autonomic dysfunction, and this sort of profound peripheral nerve hyperexcitability, and you've seen a video of this already, very similar young man here with profound peripheral nerve hyperexcitability, is the sort of pattern of features which should make you think of this disorder in particular. And what we now know is that patients with LGI1 and caspase-2 antibodies have very different genetic makeups. So the LGI1 patients have a almost universal association with DRB7, sometimes called DR7 or DRB10701 as the specific allele. Almost, I would say 95% of the patients we're seeing in clinic now have this allele. So it's an almost universal association. Whereas patients with caspase-2 antibodies tend not to have this, but have DR11, DRB11101. And so this pulls out a very fundamental difference between these two groups of patients who were, of course, once upon a time associated by a voltage-gated potassium channel and thought to be the same group of illnesses. And this distinction is highlighted further in specific endophenotypes. So here in this paper, we concentrated on the neuropathic pain seen in the patients. And there's a few things to notice. First of all, CASPA2 patients have more than LGI1 patients. More commonly, they have neuropathic pain. And secondly, the distribution is different. While both have a length-dependent glove and stocking type distribution as their dominant feature, the LGI1 patients' pain often affects their trunk and their back. Very different to the CASPA2 patients. And the other thing that's very clear is this pain, and this is a pain scoring system, improves with immunotherapy in the LGI1 patients, but seems to be much more resistant to immunotherapy in the CASPA2 patients, suggesting not only do we have different clinical features, but different responses to treatment in these two groups of patients, in addition to the different genetics I've already shown you. We were quite interested in this phenomena because we didn't quite understand how these antibodies could cause pain. And we have some insights which might be useful in this aspect. So first of all, you can see that if you take skin biopsies of healthy people, here are intraepidermal nerve fibers going between the dermis and the epidermis. But in the CASPA2 and the LGI1 patients, these are really quite sparse. And if you quantify this, you can see that the intraepidermal nerve fiber density, here's our healthy control in the healthy control range. In green is our CASPA2 patient who has no pain, so a DN4 score that's very low in the normal range. And then 3 patients with LGI1 and CASPA2 antibodies who have high DN4 scores with very low densities, almost sometimes absent. So it looks like this might be the mechanism for the pain in these patients. And if so, you might anticipate that if you could derive human sensory nerves in culture, their antibodies should bind these nerves. And that's what we see here. So these are inducible pluripotent stem cell iPSC-derived human sensory nerves. They're not myelinated nerves normally, but then we add rat Schwann cells and they myelinate. And you can see the CASPA2 antibodies bind very nicely to these cells throughout, suggesting that they are binding the native human epitope of sensory nerves. LGI1, however, and behave like healthy controls. We can't work out where these bind. We thought we'd ask the same question in rodent dorsal root ganglia, because that could be a source of the pain here. That could be a localization for the pain. But we found the same. We found that the LGI1 antibodies did not bind, but the CASPA2 antibodies do bind and bind very specifically. So they don't bind anymore if the rodent is a CASPA2 knockout animal. So why does this matter? Why trying to investigate this? Well, I think we have a model here now to test drugs potentially that might modulate CASPA2 antibody function. Because if you, and if you look at patients with a 5-year follow-up, you'll see that the CASPA2 patients do worse in all the quality of life domains that we sampled. So they are a group who need more attention, who haven't been focused on yet, and we think pain might be an important predictor of their long-term outcome. Okay, I'm going to switch tack a little bit to what I think is the second most common antibody-mediated encephalitis syndrome, associated with antibodies to the extracellular domain of the NR1 subunit of the NMDA receptor, the ubiquitous subunit. And these patients present in a way that you'll have all seen and is very stereotyped in adults. What I want to draw your attention to is they often first attend with psychiatric symptoms, and perhaps the most aspect of their syndrome, I might argue, is their movement disorder. So we were very interested in focusing in on these two aspects. And my colleague who's a psychiatry trainee, Adam Al-Dawani, had the idea of going away and trying to review the literature to understand the psychopathology of these patients. Can we pick these patients up really early with a distinctive clinical signature that might allow recognition of these patients by comparison to other primary psychiatric illnesses? So he went and reviewed adults with CSF NMDA receptor antibodies who had sufficient psychopathological detail in the reports, and we got to a really good number of patients. And this is what we saw. We had a tick box exercise, essentially a questionnaire incorporating a number of features one would routinely elicit in a psychiatric interview. And you see that the patients had features which span all these disorders, all these symptoms. And if you categorize them as the colors show here into conventional categories, you will see that the patients had disorders, problems across behavior, psychotic features, mood features, catatonic features, sleep features, and so on. They cross-cut traditional psychiatric boundaries. And in fact, the 7 key features cross-cut psychiatric boundaries. Agitation and aggression, we see this in almost all our patients. Hallucinations and delusions are very common. And then mood is massively under-acknowledged in the literature. But if you ask patients about this, they will almost all say they either were very tearful, very irritable, or very depressed. And so if you plot the data from this and you ask where are the overlaps in this disorder, really many patients sit in the middle or in a overlap region across these 5 traditionally distinct categories. So it's a really mixed syndrome. And when we were the consultant psychiatrist who used to work with me on this disorder, he used to call it a much more turbulent and jumbled syndrome than he's seen before. This picture nicely illustrates that sort of jumble, sometimes called transdiagnostic in the psychiatry world particularly. But my favorite quote of what is a very mixed and I think a very highly distinctive, although we're still analyzing the data to prove that with a number of controls. My favorite quote comes from the mother of a patient who said it was like she was in front of a buffet of psychiatric things and trying a little bit of them all. So that's the way I remember the psychiatric presentation of this disorder. And you'll also remember that the movement disorder was highly distinctive, or was very common at least. I'll show you a couple of examples of the movement disorder in this patient. And I hope you'll agree that when you're trying to give a name to this, and I noticed Div did this in his talk, it's very difficult to give a single name to this movement disorder. Some people would say this is choreiform. Others would say these are stereotypies. You can see her left hand here shows some dyskinesias, some dystonia there. So dystonic posturing. And then she has these orofacial dyskinesias. So I've already used 4 different terms in just trying to describe one video. And similarly, but very different to the LGI1 patients, for example, but similarly, you'll see it's difficult to give a single term to some of these movement disorders. And different to the LGI1 patients, though, it's not identical between patients. It does look different to the eye. And I'll just show you some examples of this patient because you've seen 2 different forms of movement disorder now. Our experts that rated these videos called that ear clutching stereotypies first. I think this is posturing now, or waxy flexibility, you might argue. And now he's got some more hyperkinetic movements, perhaps choreiform. So this is a really difficult disorder to classify with using simple nomenclature. And so what we did was we were lucky enough to ask a number of experts, movement disorder experts around the world, what they would think, what they would call these disorders. And we sat down for a morning and we showed them 80 videos on these patients. And it was very interesting that the guy who wrote the movement disorder classifications for phenomenology said it's particularly challenging to preconceived and established phenomenological characterizations. So even the experts who wrote the guidelines on how to recognize these disorders said this disorder posed problems. And in fact, when you analyze the data, you see that it goes across a number of different features. So these patients have chorea, dystonia, and stereotypies, interestingly with very little tremor. And it's that triad or quartet which really marks this disorder out as distinctive. And so in summary, NMDA receptor antibody encephalitis clinically to me is a very complex disorder. It's complex in the number of symptoms patients appear with or number of features they appear with. It's complex within the psychopathology. This is an example of where you try and cross-match the psychopathology features. It's very complex to describe this. and it's complex within the movement disorder. As you know, these patients often have ovarian teratomas. So I would say about 20% of our patients in total have ovarian teratomas. And as we recognize more men, and as we recognize females outside of the typical age band, and as we just recognize females more with this disorder, the teratoma rate has gone down and down over the years. But what is it about these teratomas which biologically makes them part of this disease? So the first thing we noticed was a very simple histological observation, which was that these patients often have within their teratomas these lymphocyte dense infiltrates with CD3 cells, with CD20 densities, so B cells as well as T cells. You can see plasma cells marked by CD138. And then perhaps most interestingly, dense expression of the autoantigen, the NR1 subunit. And this reminded me of germinal centers, because this is what a germinal center should look like. T and B cells opposing and antigen present. And in fact, when you look at this using multi-parameter immunofluorescent imaging, you can see that the teratomas look very similar to conventional lymph nodes. So this is an example of a lymph node from a patient, and you can see these B cell densities in classic follicles surrounding these AID, so an enzyme involved in class switch recombination and somatic hypermutation, a key transcription factor, BCL6, in defining germinal center B cells. CD21 is a marker of dendritic cells which present antigen, and podoplanin and PNAD are markers of the lymphatics and the high endothelial vasculature respectively. So this is a classic lymph node architecture, but it is from a lymph node, whereas this one is from a teratoma, and it looks remarkably similar. You get B cell aggregates, you've got AID, BCL6, CD21, podoplanin, PAND, it's all there. In my view, these are germinal centers, and these are essentially tertiary lymphoid organs. So the real question is, does the teratoma harbor NMDA reactive B cells? Is it actually the seat of this immunization as a germinal center? And so what we looked at was we took the teratoma, we knew it had these densities within it. And so what we did is we just took small chunks of it, sometimes called explants, and we cultured them, or we extracted and isolated the B cells from within the teratoma, and we took the B cells and explants and we put them in culture. And when we culture them, we ask, are NMDA reactive antibodies secreted during the culture process? And it was very intriguing, because in all situations, essentially, NMDA reactive antibodies were produced by the teratoma resident B cells. So I think it's not just a germinal center structurally, but functionally acts as a germinal center. And so this feeds into our overall model of how these diseases might operate. And I'm going to spend just a minute or two on this slide, because I want to talk you through a few observations which I think allow us to understand where we might give drugs to patients and where we might be best placed giving these in the future. The first observation is that I think these diseases in general, and I include NMO in this, and I include MOG-AD in this, because these diseases in general must arise from antigen in the CNS spilling out into the periphery, because we know from the old experiments of Medawar and colleagues that a CNS autoimmunization is insufficient to generate a response against that. And the last few years have taught us that cervical lymph nodes may be the place that the meninges drain to, and that the CNS drains its antigens to. And in the cervical lymph nodes, we have T and B cells cooperating, which may migrate back to the central nervous system then. So our final question was, do these lymph nodes in patients harbor NMDA reactive B cells? And so we sampled lymph nodes from humans and paired this with peripheral blood. And most importantly, we performed cell culture on these aspirates. And what we found consistently is, whereas in disease controls with encephalitis, but not NMDA receptor antibody encephalitis, neither the blood nor the lymph nodes made NR1 reactive antibodies, In the patients, both the blood and the lymph nodes commonly made NR1 reactive antibodies, sometimes and tended to be the patients with the higher serum titers of the antibodies. So just to conclude my final slide, I'd like to emphasize that these are often highly clinically distinctive phenotypes, if not pathognomonic phenotypes. And we're getting really interested in how the B-cell immunology can be evaluated directly from the patients, from blood and less accessible lymph node compartments, to identify key biomarkers, to identify B-cell populations which might harbor the autoantigens, and to guide treatment decisions in the future. I think this is the way we can think about which drug, when patients relapse, how long to give drugs for. And of course, by studying the B cells, you can also harvest that monoclonal antibodies and study the neuroscience that goes downstream of them. So I'd like to thank many people in the lab. This is how the lab started in 2013, and this is how we are now. And especially the people and the funders who are critical to the work I presented today.
I think we are running behind time. We can entertain a question or two from the audience. Can we have a mic there, please, Dr. Bing, sir?
Sarosh, thank you very much for that excellent presentation. Just to find out about patients who are having ovarian lesions other than teratomas, are they significant? Because we have had a few patients who are having definite seropositive NMDA receptor antibody encephalitis, having ovarian cysts and other ovarian lesions, not teratomas. Are they significant?
I mean, that's very interesting. I suppose there's two answers. One is that clearly ovarian cysts, luteal cysts, etc., are very common generally. So your question is pertinent to that far more common than this kind of presentation, of course. And then that might argue that they're not. I suppose the definitive way to go about it would be to see if you could detect the antigen within the tumor or within the cyst. We have seen a couple of cysts recently in the thymic region of our patients, and we opted to take them out with other illnesses. And one of them did express the antigen of interest. So I think it's not impossible that these things exist. It might be a fundamental property of the ovary rather than the ovary and the teratoma, but I think it needs to contain the antigen to be a true paraneoplastic association.
Sarosh, can I ask you a quick question about ovarian teratoma? Now, when the antigen express and antibodies are formed, how do the antibodies cross the healthy blood-brain barrier to cause the disease?
Yeah, so my view is that they don't, or that they do in very low quantities. I think the B cells cross. And what we know from studies of the CSF of these patients is even when you and I receive a result which says there are very few lymphocytes in the CNS, actually if you do flow cytometry, it's teeming with B cells, but loads of plasma cells in there, and they have a very high proportion of which are NMDA receptor antibody reactive. So I think that's the dominant mechanism going on in these diseases.
In the absence of any other questions, we can end this, and I think every talk had been very interesting, but now we are going to wait the most awaited program by